Oh, macam kat YouTube. Saya rasa dah ada tak? YouTube saya search kan. Ada link dekat mana? Tak apa link.
Saya suspek orang-orang yang first time masuk. Orang-orang yang
Apa nama ni? Nama Anis ni. Dia dah masuk. Anis nama apa?
Nama tak ada. Anis Muhammad tak ada. Dah keluar bawah.
Ada. Sekretari tu ada. Oh.
Ke sekretari tu?
Ke sekretari tu. Sebab dulu pun tak betul. Tak bukan nama lagi. Saya try tu.
Itulah sekretari tu.
Okay, saya jadikan Anis Pokok.
Apa nama nanti?
Pada saya share sekarang, kita sudah jadikan fokus. Ni fokus. Okay, Anis suka nama
Bolehlah kita letak MC.
Nampak ni Nampak ni
Nampak ni sekarang.
Oh, lupa projector. Ni dah Anis boleh buka dulu.
Sabar, tukar nama macam mana dah?
Tukar nama. Ya, virtual background tu ada dah kan?
Semalam kita letak dah.
Tak dah lah. Kita buka sekejap test. Kita tak email lagi. Dengan mana?
Tak, MC.
Setiakan.
Yang ni saya ingat
Bengkel Electroconvulsive Pahang pun boleh.
sama yang ni.
Itu sama. Urus setia lah saya letak
Dari
MC Bengkel.
MC
Ya.
HTA. Kalau
Dia
saya
live macam ni. Tak pasti dia ini load sebab phone saya pun
dia macam tu kan.
yours okay?
Oh, tu
Maybe. Saya mesej pun masuk. Cuba sekali.
Dah tukar tak nama? Dah tukar tak nama? Sudah.
Dah
Belum kan? Okay dah. Macam tak sensitif. Dah ada tekan.
Saya option.
Saya pernah masuk dalam biasa, tapi dia betul-betul
Dengan perkataan.
Saya tak ingat apa ini. Saya rasa itu kenapa pelik. Silap tanya. Memang Anis punya yang dia dengan speaker.
Oh, okay.
Mbak Anis nak bercakap nanti.
So, kalau saya nak cakap, saya kena off speaker. Biar je.
Ya, dia. Sebabnya Anis punya yang link dengan ini awal-awal je. Lepas ni sebelum doa tak boleh tau.
Saya buat Fatihah saja. QR code, MMA dengan kehadiran, MMA CPD tengah-tengah masa rehat.
Masa rehat. Senang. Kalau tak ada kita kan.
Pada bilik saya, cuba bagi kita jadi co-host dengan share screen tengok.
Oh, apa nama
Dr. Tanggatin Dr. Cik.
Dr. Cik.
Tanggatin Sir Dr. Cik.
Okay. Dr. Milin, apa nama dia?
Nak tanya tak, Dr. Cik?
Tapi Dr. Milin dia memang tahu dah dia akan buka daripada sana.
Dah dua. Siapa lagi yang
Suara, dengar tak suara saya? Dengar? Anis? Anis, dengar tak? Okey.
yang tu start video kamera? Kau dah kenapa tiba-tiba? Settings.
formula yang pendaftaran sempurna.
Assalamualaikum dan salam sejahtera. Semua peserta bengkel hendaklah memastikan mikrofon masing-masing berada dalam keadaan off untuk melancarkan bengkel kita pada hari ini. QR kod kehadiran MMA dan MyCPD akan dipancarkan semasa sesi rehat nanti. Dan nanti kita akan pancarkan waktu rehat lah. Okay, terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Sebelum kita teruskan bengkel kita pada hari ini, marilah kita buka bengkel kita dengan bacaan surah Al-Fatihah. Yang berbahagia Dr. Hajah Nurul Amilin binti Harun, Ketua Perkhidmatan Psikiatri Negeri Pahang, yang berusaha Dr. Haryani Ishak selaku Ketua Jabatan Psikiatri dan Kesihatan Mental Hospital Tengku Ampuan Afzan, yang berusaha Dr. Chi Jun Heng selaku Pengerusi Bengkel ECT, AJK program dan para peserta yang dihormati sekalian. Selamat datang ke Bengkel Electroconvulsive Terapi Peringkat Negeri Pahang 2023, anjuran Jabatan Psikiatri dan Kesihatan Mental dan Jawatan Kuasa Electroconvulsive Terapi Hospital Tengku Ampuan Afzan. Para peserta, apakah itu Electroconvulsive Terapi? Adakah rawatan ECT ini seperti yang kita lihat dalam filem atau drama yang dilakukan tanpa pemantauan khusus? Apakah fungsi ECT dan bagaimanakah cara untuk melaksanakannya? Soalan-soalan ini insya-Allah akan terjawab dalam bengkel kita pada hari ini. Objektif utama kita pada hari ini ialah untuk menyelaraskan pengetahuan dan kemahiran kaki tangan yang terlibat dalam perawatan ECT dan untuk memastikan rawatan ECT ini diberikan mengikut garis panduan yang terkini. Untuk pengetahuan semua, bengkel pada hari ini dilakukan secara hybrid dan melibatkan ahli jawatan kuasa ECT, kaki tangan Jabatan Psikiatri dan Kesihatan Mental di hospital-hospital Negeri Pahang, termasuklah di HTAA, Hospital Sultan Haji Ahmad Shah Hoshas, Hospital Bentong dan Hospital Kuala Lipis. Sebelum kita memulakan bengkel kita, para peserta diingatkan untuk menjawab soalan pre-test. Link untuk pre-test akan diberikan di chat box. Tanpa melengahkan masa lagi, dengan segala hormatnya saya menjemput Dr. Hajah Nurul Amilin binti Harun, Ketua Perkhidmatan Psikiatri Negeri Pahang untuk menyampaikan ucapan beliau dan seterusnya merasmikan bengkel kita pada hari ini. Dengan segala hormatnya, mempersilakan doktor.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh dan salam sejahtera. Terima kasih Puan Pengerusi Majlis Dr. Anis, yang berusaha Dr. Chi Jun Heng, pakar psikiatri HTAA merangkap pengerusi jawatan kuasa bengkel ini, yang dihormati barisan para penceramah, pakar-pakar dan juga AJK program serta para peserta yang saya raikan sekalian. Alhamdulillah, segala puji dan syukur kita panjatkan kehadrat Allah Subhanahu Wa Taala kerana hanya dengan limpah kurnia dan inayahnya juga kita masih diberi kesempatan untuk bersama-sama menghadiri bengkel anjuran Jabatan Psikiatri dan Kesihatan Mental dan juga jawatan kuasa Electroconvulsive Therapy ataupun ECT Hospital Tengku Ampuan Afzan. Sebagaimana yang Puan Pengerusi Majlis kita dah sebut tadi, bengkel ini memang kita adakan secara hybrid melalui aplikasi Zoom. So secara fizikalnya kaki tangan Jabatan Psikiatri Kesihatan Mental di HTAA ada boleh menghadiri secara fizikal dan saya mengalu-alukan kehadiran secara virtual bagi peserta daripada Hospital Sultan Haji Ahmad Shah, Hospital Bentong dan Hospital Kuala Lipis. Untuk makluman, buat masa ini bagi Perkhidmatan Psikiatri Negeri Pahang, perkhidmatan ECT secara aktifnya disediakan hanya oleh Hospital Tengku Ampuan Afzan, tetapi in the pipeline Hospital Bentong akan memulakan perkhidmatan ECT harapnya dalam tahun inilah. So mesin ECT mereka sudah ada dan diharapkan juga Hoshas berjaya untuk mendapatkan mesin ECT supaya mereka juga boleh memulakan perkhidmatan ECT. Jadi walaupun hospital-hospital yang lain masih belum memulakan perkhidmatan ini, diharapkan bengkel yang kita akan adakan ini dapat memberi semangat dan juga memberi informasi yang sepatutnya kepada semua yang akan memulakan perkhidmatan ini. Di kesempatan ini saya ingin mengucapkan selamat datang dan tahniah kepada para peserta yang telah sudi meluangkan masa untuk mengikuti bengkel yang akan berlangsung selama setengah hari. Dan saya juga ingin merakamkan ucapan setinggi-tinggi penghargaan dan syabas kepada semua AJK bengkel yang diketuai oleh Dr. Chi kerana berjaya melaksanakan tugas dan tanggungjawab yang begitu baik untuk menjadikan bengkel ini. Para peserta yang dihormati, Electroconvulsive therapy merupakan rawatan yang berkesan dan selamat untuk pelbagai jenis penyakit mental seperti kemurungan, kecelaruan bipolar dan juga skizofrenia. Ia juga bermanfaat untuk pesakit-pesakit yang mengalami kecenderungan untuk membunuh diri yang tinggi. Rawatan ECT akan dimulakan apabila pakar yang merawat merasakan gejala penyakit mental tersebut perlu dikawal dengan segera. Ataupun dalam kes yang berisiko tinggi seperti kecenderungan bunuh diri yang seperti disebut tadi, dan juga jika terdapat kecenderungan bagi pesakit ini untuk mencederakan pesakit lain. ECT juga turut digunakan dalam kes di mana ubat-ubat tidak berkesan atau pesakit mengalami kesan sampingan ubat yang membahayakan. Ia adalah rawatan yang perlu dikendalikan oleh doktor yang bertauliah ataupun credential setelah menerima latihan di bawah seliaan. Jadi selaras dengan ini, garis panduan Guidelines on Electroconvulsive Therapy for Ministry of Health telah diterbitkan oleh Bahagian Perkembangan Perubatan Kementerian Kesihatan Malaysia dan juga Perkhidmatan Sekretari Kementerian Kesihatan Malaysia. Dan satu latihan ataupun kursus di peringkat kebangsaan telah diadakan pada tahun lepas, di mana negeri kita telah menghantar beberapa orang peserta daripada HTA dan juga HOSHAS. Jadi bengkel ini adalah satu eco-training yang kita harapkan dapat memperkenalkan Guidelines on Electroconvulsive Therapy for Ministry of Health, the basis, practicalities and policies kepada kaki tangan Jabatan Sekretari dan Kesihatan Mental di Hospital Negeri Pahang. Dan sebagaimana yang disebut tadi adalah untuk penting untuk kita menyelaraskan pengetahuan dan kemahiran para kaki tangan dan juga bagi memastikan rawatan ECT ini selamat diberikan mengikut garis panduan yang teliti. Saya amat mengharapkan agar semua peserta bengkel pada hari ini dapat memanfaatkan ilmu yang dikongsi untuk menambah baik perkhidmatan kesihatan masyarakat kita amnya dan menambah baik keberkesanan perkhidmatan sekretari di seluruh negeri Pahang khususnya. Sebelum saya merasmikan bengkel ini, izinkan saya untuk berpantun. Sebenarnya semalam saya telah diberi amanah untuk memberi taklimat di khusus taklimat OKU dan ada pengurusi memberi pantun pada saya tapi saya tak pandai nak jawab. So tiba-tiba semalam inspired untuk membuat pantun lah. So pantun pertama ni saya try sendirilah. Ia berbunyi, segak pemuda berbaju kemeja, peneman Cik Siti datang bertamu. Walau kita sudah lama bekerja, jangan berhenti menimba ilmu. Pantun kedua ni daripada DBP Anak kecil memungut jambu, sudah kenyang lari ke hutan. Sejak kecil menuntut ilmu supaya senang hari kemudian. Jadi yang lafaz yang bismillah, saya dengan ini merasmikan Bengkel Electroconvulsive Therapy Peringkat Negeri Pahang 2023. Sekian, wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi taala wabarakatuh.
Warahmatullahi wabarakatuh. Okay, terima kasih Dr. Milin atas ucapan dan perasmian sebentar tadi. Kami berharap agar pesanan beliau dapat dijadikan sebagai panduan untuk kita semua. Para peserta, kita ada sedikit perubahan tentatif untuk program kita pada pagi ini. Kita akan berehat selepas ceramah pertama yang akan disampaikan oleh Dr. Tan Kai Pin. Selepas rehat, baru kita akan bersambung dengan ceramah daripada Dr. Chi Jun Heng dan terus ke ceramah ketiga lah yang terakhir. Jadi sekarang kita akan mulakan kita punya ceramah pertama. Sesi ceramah pertama kita akan disampaikan oleh Dr. Tan Kai Pin yang bertajuk Introduction and Indication for ECT dan Adverse Effect of ECT. Sebelum beliau memberi ceramah, para peserta diingatkan sekali lagi untuk menjawab soalan pretest melalui link yang telah diletakkan di chat box. Nanti selepas habis kita punya bengkel, kita akan buat post test pula supaya kita boleh compare pengetahuan pre-test dan selepas bengkel lah post test. Sedikit pengenalan berkenaan dengan Dr. Tan Kai Pin. Dr. Tan Kai Pin merupakan pakar psikiatri di Jabatan Psikiatri dan Kesihatan Mental HTAA sejak Ogos tahun lepas 2022. Sebelum itu, beliau telah berkhidmat di Hospital Selayang Selangor. Beliau telah menamatkan pengajian dalam Master of Medicine Psychiatry di Universiti Putra Malaysia. Kini, beliau bergiat aktif dalam aktiviti dalam peringkat jabatan dan juga di peringkat negeri Pahang. Tanpa melengahkan masa lagi, dengan segala hormatnya, saya menjemput Dr. Tan Kai Pin untuk menyampaikan ceramah beliau. Dipersilakan, Doktor.
Okey. Terima kasih Anis. Selamat pagi kepada semua pakar-pakar, pegawai perubatan, houseman dan juga paramedik yang menyertai khusus hari ini, khusus ICT hari ini. So, ingin bertanya sama ada semua peserta sudah menjawab soalan pre-test ke? Ataupun saya bagikan 3 minit untuk bagi semua peserta untuk jawabkan pre-test dulu sebelum saya mulakan saya punya sharing terhadap topik-topik yang diberikan. Boleh? Link untuk pretest telah dikongsikan dekat chat box. Okey, tanpa melengahkan masa, saya ingin mulakan saya punya presentation hari ini. Okey. Boleh tak nampak sharing saya, screen sharing saya? Sekarang? Boleh, okey. Okey. So, saya diberikan tugasan untuk membentangkan topik bagi introduction and indication dan juga adverse effect of electroconvulsive therapy. So, seperti yang kita fahami, ECT adalah stands for electroconvulsive therapy. Dan selain daripada topik yang diberikan, saya tambah juga 2 bahagian yang agak penting dalam kita punya guideline untuk dikongsikan pada hari ini. Iaitu selain daripada introduction and indication for ECT, saya tambahkan contraindication of ECT, selain daripada adverse effect of ECT dan juga pharmacotherapy in ECT. So saya akan topik saya akan melingkungi 5 subtopik ini. Jadi presentation saya pada hari ini adalah based on being referred from this guideline on electroconvulsive therapy for Ministry of Health the basis, the practicality and the policies daripada Medical Development Division, Ministry of Health Malaysia. Okay, so before that, let's kita warm up sikit-sikit. Boleh tak semua orang scankan QR code ini untuk jawabkan dua soalan. Okay, soalan dia adalah, how confident are you in prescribing ECT for your patients? Dan seterusnya soalan kedua adalah, how old is ECT in years? Okay, so semua orang sila scankan QR code ini dan kita ada sikit interactions. Okay, yang tak dapat scan tu masih sempat untuk scan QR code itu. Okay, so nampaknya, even though kita ada sebanyak dekat 150 participants, tapi nampaknya cuma ada kurang daripada 30 yang jawab soalan lah, tapi tak apa. So in general, kita kalau tengok percentage tu, agak-agak 50% daripada kita punya participant hari ini adalah confident untuk prescribing ECT. Then followed by another more than 25%, I would say about 30% plus, which is not so confident in prescribing ECT. So it is good for us to take this opportunity during this ECT course to learn more about ECT dan untuk boost up our own confidence in prescribing ECT in our patients later. Okay, so the next question which will appear in your Mentimeter is, how old is ECT, do you think, in years this year? All right, let's answer. Don't worry if you get the answer wrong, just try and error. Okay, roughly we have quite an average distribution of the answers from less than 60 years to more than 100 years. But most of our candidates thinks that ECT is about 70 to 80 years old tahun ini. Biar kita tengok apakah jawapan yang sebenarnya. Okay. Okay, so before we understand what is ECT, it's good for us to have some exposure in regards of the history of ECT. In 1934, Ladislas Meduna used epileptogenic agent to treat a mute catatonic patient. Maksudnya, dia menggunakan, dia daripada Hungarian. So this neurologist ni, dia gunakan epileptogenic agent, ubat yang boleh trigger epilepsi untuk merawatkan pesakit yang catatonic dan mute, selective mutism tu. In 1938, which is 4 years later, Ugo Carletti and also Lucio Bini, they are Italians, they induced electrical seizure on a disorganized man with schizophrenia wandering at a train station in Rome. So maksudnya mereka Ugo Carletti is the father of ECT. Dengan kawan dia sekali, Lucio Bini, mereka yang first gunakan electrical seizure yang seperti ECT yang kami buat sekarang untuk merawatkan seorang pesakit yang ada skizofrenia. Selepas tu, Wazimir Liberson shortened the stimulus duration to reduce aphasia, cognitive blunting, and recovery time 6 years later. So dia dapati ECT boleh menyebabkan side effects macam aphasia, cognitive blunting, and also recovery time. So dia pendekkan stimulus punya duration. He made amendment and also improvement to the ECT treatment. And subsequently, in 1952, Homburg and also Teslev from US, they introduced modified and anesthetized ECT. So, which is the basic of our ECT currently. Of course, over the years, there are further improvement and also amendment of the ECT treatment over the years to the extent until what we have now and what we are practicing now. So these are some old articles and also old photos of the ECT that has been done decades ago. All right. So an introduction to ECT. ECT is a form of physical therapy, sejenis physical therapy, di mana kita deliver electrical charges to the brain in a controlled manner and relatively brief duration to treat certain psychiatric illnesses. So dalam keadaan yang terkawal dan kontrol, iaitu anesthesia. Alright, and also everything is under control in terms of the energy level that we are delivering. It is modified with evidence-based innovation in techniques and advances in our clinical application since mid-1980s. So maksudnya terutamanya selepas tahun 1980-an, dah makin modified dengan innovations and also advanced in clinical implications. Our ECT is governed by local legislation and policies, which is our Mental Health Act and also Mental Health Regulation. It is safe and effective with minimal adverse effect, minimal side effect, than the first line of treatment for certain conditions rather than treatment of last resort, which we always think so and we always practice all this well. So dengan information ini, this is a good summary bagi kami untuk menjelaskan kepada kandidat, kepada pesakit-pesakit kami dan juga family dengan menggunakan introduction ini sebagai untuk memperkenalkan ECT sebagai salah satu rawatan bagi pesakit. So what are the factors to consider bila kita nak prescribekan ECT? Sebab kita tidak akan prescribekan ECT kepada semua pesakit, kan? So, yang pertama, apakah diagnosis? Sesetengah diagnosis yang sesuai untuk yang ECT akan menunjukkan efficacy. Sesetengah diagnosis, psychiatric diagnosis tidak. Selepas tu we also have to look into severity of the symptoms. Mild one less likely requires ECT. Severe one, yes. And also urgency of the response needed. For example, how fast you need the patient to get recovered. Okay, contohnya patient yang actively suicidal or actively aggressive, not responsive to pharmacological treatments, or having some self-harm behavior or self-neglect until medically unstable. So urgency of the response is required. Next, potential vulnerability to cognitive and physical adverse effect. So kita kena consider juga, what are the risks of the side effects of ECT to the patients and how likely they are going to experience those side effects. We will also consider ECT if patient previously good response to ECT. Okay, next, if we also have to consider patients' coexisting medical condition, whether it becomes a relative contraindication for ECT or we need to further optimize the medical condition before we start the ECT. And last but not least, some other patient is on concurrent use of medical or other psychiatric medications which will interfere or interact with the ECT or the anesthesia or the anesthetic agents that is used by anesthesiologists. So if you look at the indication, there are few indications that we can consider ECT for our patient. Number one, depressive disorder, especially major depressive disorder. Sama ada mereka ada psychotic features with melancholic features or with peripartum onset. Next, bipolar disorder. in whichever episodes, manic, major depressive episode, or mixed episode. Of course, like mentioned by Dr. Amilin just now, psychotic disorder, for example, schizophrenia, schizoaffective disorder, puerperal psychosis, all right, in acute phase with treatment-resistant or prominently disorganized features. The fourth indication is catatonia. So catatonia, patient with catatonia will be, ECT will be very efficacious in patients with catatonia. But of course, before we conduct ECT for that patient, we need to identify any reversible medical conditions or not. So we need to perform medical or neurological workup prior to ECT. So definitely we should refer to the medical or the neurology discipline in assisting us to rule out this as well. And we have to aware that malignant catatonic is life-threatening. Therefore, ECT should be administered early rather than we keep delaying it. The next one would be neuroleptic malignant syndrome, NMS. Okay, with NMS, besides discontinue antipsychotic prior to initiating ECT, we need to stabilize their autonomic function as well. Contohnya kena pastikan BP, pulse rate, temperature semua is already stabilized and achieved before kita startkan ECT. And the next one would be autistic spectrum disorder. Bukan semua pesakit yang ada autism kita akan start, tapi ECT would be indicated sekiranya mereka ada repetitive self-injurious behavior or challenging behavior. Because patient with severe autistic spectrum disorder, they might have a lot of behavioral issues ataupun tendency to harm themselves. So this would be indicated. ECT has shown a decrease in self-injury, elimination of catatonic symptoms, acquisition or recovery of their functional life skill, and also even return to the baseline functioning. And in patients with ASD and behavioral issues who requires ECT, maintenance ECT is often required to sustain improved clinical status. Seterusnya, indikasi seterusnya adalah intellectual disability. For example, especially those with challenging behavior, seperti dalam pesakit yang ada ASD. Comorbid, or if they have comorbid mood disorders, sama ada unipolar or bipolar depression. These evidence are mainly derived from case report or case studies. Next one will be major neurocognitive disorder or dementia. Okay, patient with dementia with BPSD, for example, behavioral and psychological symptoms of dementia, contohnya agitation or aggression, ECT would help to reduce the agitation and also psychotropic polypharmacy. So kita tidak perlu menggunakan terlalu banyak jenis ubat bagi pesakit demensia, di mana ini akan menyebabkan mereka ada lebih banyak komplikasi ataupun side effect daripada ubat. And ECT will improve the global functioning level as well of the patients with dementia. And lastly, Parkinson's disease. Those patients with Parkinson's disease, yang kita faham Parkinson's disease ada motor dengan non-motor sign. Kan? So motor sign, contohnya tremors, bradykinesia, rigidity. If these symptoms are not responding to medications, ECT would be helpful. Juga, kalau patient with Parkinson's disease ada non-motor symptoms ataupun neuropsychiatric manifestation, contohnya refractory psychosis, depression ataupun catatonic stupor, ECT will be indicated. Tapi sebelum kita buat ECT, kita kena consider adjusting the dose of the anti-Parkinsonian agent, okay, during the course of ECT to prevent possibility of treatment-emergent dyskinesia or psychosis. So bila kita akan consider ECT itu sebagai first line, bila kita akan consider dia sebagai second line. First line, first line treatment means prior to a trial of psychotropic medication, sebelum kita bagi ubat psychiatry, okay, where rapid and definitive response is required due to severity of psychiatric or mental illness. Contohnya, kita kena patient improve dan juga sembuh dengan cepat. Contohnya high suicidal risk, actively suicidal, even dalam work pun attempt contohnya. Severe psychomotor retardation with associated problems, contohnya poor oral intake, tak makan langsung sampai medically unstable, electrolyte imbalance, hypoglycemia contohnya. So compared to second line treatment means kita dah try psychotropic medication tapi fail. So contohnya dalam keadaan deterioration of psychiatric or medical condition and the need of rapid definitely response, severe prolonged mania with persistent, contohlah, with persistent life-threatening symptoms. Okay, so we will also consider it as a first line bila we risk the other alternative aid treatment outweigh the risk of ECT. And we know that there are previous good response to ECT, especially treatment-resistant depression. So in this kind of cases, kita akan consider first-line treatment. Patient masuk ward unwell, so lepas tu kita akan start ECT terus. Okay, compared to second line, kalau patient dah makan ubat tapi develop adverse side effect, tak boleh tolerate ubat high dose, banyak side effect, ataupun ada treatment-resistant cases, especially depression, kita akan consider sebagai second-line treatment. Of course, our management, tak kisahlah management dari segi pharmacology ke, ECT ke, is always shared decision making. So adalah important bagi kami untuk consider patient's preference juga dengan our judgment. So kalau patient rasa dia nak ECT sebab sebelum ni efektif, we should consider ECT as well as the first line treatment. So after we talk about indication, now let's talk about contraindication. In general, there's no absolute contraindication for ECT. Dia ada contraindication kata mesti tak boleh buat. Tapi ada relative contraindication, terutama dalam pesakit yang ada comorbid medical illness. Patient-patient yang ada comorbid medical illness yang tak stable, especially precautionary intervention is required. There are few principles that we can figure out from this management. Definitely, kalau patient ada comorbid medical illnesses, we should consult the respective discipline. Neuro ke, medical ke, surgery ke, ENT ke, ophthalm ke, NS ke, we have to consult them, okay, to get their input regarding whether patient is fit to proceed with ECT or not. And those patients with comorbid medical illnesses, we have to optimize the medical illnesses before the ECT. If we can't optimize it, then maybe we should consider postpone the ECT until the patient is medically stable. Ataupun we can also consider giving some prophylactic medications prior to ECT to ensure that patient would not get into another medical crisis during the course of ECT. If the medication used for the comorbid medical illness has the risk of potential interaction with our ECT or anesthetic drugs, we should avoid those medication, change it, or at least keep it at the lowest effective dose. So these are the few principles that we should have in our mind bila kita nak prescribe patient with ECT. Let us look into each system. If patient has cardiovascular disease, for example, we have to understand in general, patients with cardiovascular disease are at higher risk of arrhythmia, heart attack, myocardial infarction, myocardial rupture, or even cerebral aneurysm rupture due to the sympathetic and parasympathetic activation during ECT session. Sekiranya pesakit ada hypertension, we need to optimize their blood pressure before ECT. So kita tak boleh hantar pesakit untuk buat ECT kalau BP dia masih high, hypertensive or hypertensive urgency, or even hypotension, hypertensive urgency. In patient with previous history of asystole during previous ECT, we should consider giving IV atropine or glypyrrolate prior to ECT and use unilateral electrode placement. Okay, of course, we have to consult medical or cardiologist in terms of that. Sekiranya pesakit baru-baru ni baru ada myocardial infarction, we should consider to perform ECT after 60 days of myocardial infarction according to American Cardiac Association or American Heart Association's guideline. If patient have cerebral aneurysm rupture before, we should optimal the blood pressure control prior to ECT and even consult neurosurgeon. For patient who has cardiac implantable electronic devices, CIED, contohnya pacemaker, consult cardiologist, where comprehensive interrogation prior to ECT would be required. Let's talk about patient with comorbid neurological diseases. Sekiranya pesakit pernah ada stroke, to perform ECT after 4 weeks after stroke, if there's no major risk of reinfarction or rebleeding. So tak kisahlah sama ada itu hemorrhagic stroke ataupun ischemic stroke, 4 weeks at least. Dan after assessment, dan kita pastikan dia tak ada risk of sekali stroke lagi. For patient with intracranial space occupying lesion, the old study would say that siapa-siapa yang ada tumor dalam sama ada tumor ataupun cyst dalam otak is a absolute contraindication. However, the more recent studies has proved that ECT is safe in cases kalau dia punya SOL tu tumor tu adalah small, slow growing without any mass effect or perilesional edema. Of course, we can use steroid, antihypertensive, diuretics or hyperventilation prior to ECT to reduce the risk of coning. Maksudnya kita tak nak bila kita buat ECT tu, dia punya brain tu ada coning effect ke kita punya spine tu. The next one will be Parkinson disease. As mentioned earlier, there are indications for patient with Parkinson disease to for indication of ECT in patient with Parkinson disease, both motor and non-motor symptoms. But we need to adjust the dose of anti-Parkinsonian agent during the ECT course. It is also recommended that right unilateral ECT to minimize the risk of delirium and also cognitive impairment, which can exist itself in Parkinson disease. Sama juga bagi pesakit yang ada dementia, it is recommended to use right unilateral ECT to minimize the risk of delirium and also cognitive impairment. For patient with epilepsy, dia tak ada contraindication for ECT. Tapi masalah dengan pesakit yang ada epilepsy adalah the medication that they are on, anti-epileptic drugs. Okay, ECT is actually a kind of seizure that we are induced in patient. So all sorts of anti-epileptic drugs which are commonly used as mood stabilizer in our psychiatric setting as well will actually reduce the seizure threshold. Increase the seizure threshold. So it's hard to achieve the response that we need in ECT. Therefore, kita kena bincang dengan neurologist untuk adjustment of the dose. In patient with multiple sclerosis, MS, we should replace succinylcholine with rocuronium because succinylcholine will cause hyperkalemic crisis, and this will lead to cardiac arrest during ECT. If we are talking about patient with comorbid metabolic ataupun endocrine issue, possible devastating metabolic or endocrine complications during ECT may occur. So we need to identify and treat first. Kalau ada electrolyte imbalance, contohnya hyperkalemia, hypokalemia, hyponatremia, we need to correct it before ECT. If hyperthyroidism, there's no specific recommendation despite theoretically other risk of thyroid storm if untreated and we perform ECT. For diabetes mellitus, we need to optimize the glycemic control prior to ECT to prevent hyperglycemic state. And in patient with Addison disease, prophylaxis hydrocortisone prior to ECT would be indicated to prevent Addisonian crisis. For patient with contohnya ada end-stage renal failure. Okay, so if patient doesn't have end-stage renal failure, it's good for us to do baseline blood investigation, which includes renal function pre-ECT to detect any abnormality and also to correct necessarily. Tapi if patient is a known case of end-stage renal failure on dialysis, we should commence the ECT on the day after hemodialysis to reduce the risk of hyperkalemic complications during ECT. Patient yang ada respiratory punya issue, if patient is actively smoking, we should advise patient to cease smoking at least 24 hours prior to ECT. plus minus nicotine replacement therapy lah sekiranya mereka ada withdrawal symptoms. This is unlikely to happen because at this point of time our ECT is performed as inpatient service, but this would be applicable if our ECT is performed as a daycare service in in future settings or in other centers. For patients with comorbid COPD ataupun asthma, we need to optimize the pre-existing condition with bronchodilators and also adequate pre-oxygenation prior to ECT. Okay, so that they will not have saturation drop during the course of ECT. Also, if patient is on theophylline, we should change or keep at the lowest effective dose because theophylline has the risk of reduced seizure threshold and causing status epilepticus. If patient ada obstructive sleep apnea, anesthetic assessment is required because there's a risk of collapsed upper airway, diminished lung reserve oxygenation, and difficulty intubation. So kita kena bagi tahu NS bahawa pesakit ni ada OSA, so that they will do their assessment and also preparation for the patient. Even in patient with glaucoma, it's also important for us to refer to consult our ophthalmologist as well. Sebab anti-glaucoma drops can actually cause increased intra-optic pressure. So caution with the use of long-acting anticholinesterase drug, for example, ecotiophase, because that will increase the risk of prolonged acetylcholine-induced apnea. For patient yang ada implant, contohnya DBS, deep brain stimulation, remember to consult neuropsychiatrists or neurologists. We need to deactivate the DBS stimulator and place the stimulus electrode as far as possible away from the DBS. Sebab kita takut ECT itu akan rosakkan DBS implant tu dalam otak. For patients yang ada cochlear implant, we have to consult otologist juga. We have to deactivate it dan place the stimulus electrode as far as possible from it. For patients yang ada skull defect atau sama ada metal implant ke tak, we will consider ECT to map the implant, CT brain to map the implant or defect location. Then we will place the electrode sejauh yang boleh ataupun equidistant, tengah-tengah antara defect itu. Dan last but not least, macam saya mention tadi, untuk pesakit yang NMS, ECT is an indication, but we have to discontinue antipsychotic and also achieve autonomic stability. So kita juga kena avoid use of anesthetic agent which might trigger malignant hyperthermia. For example, succinylchlorine, also halogenated volatile anesthesia. Yang ini semua expertise di bawah NS lah. Dan last, kalau pesakit ada morbid obesity, it's more of the NS punya concern. When we have to increase the functional residual capacity and oxygen reserve to prevent life-threatening desaturation during induction. Kita juga akan consider gastric acid prophylaxis with safe anesthetic technique to minimize risk of aspiration. So, how about the side effect? Kita selalunya patient ataupun family members akan sangat takut dengan kesan sampingan. Sebab ECT sounds like it's a very serious and very canggih punya and scary punya procedure. Actually, ECT is one of the physical therapies with a low risk of severe complication. Memang low risk. And it is one of the safest medical procedure under general anesthesia. Sangat selamat. The mortality rate is extremely low because death is extremely rare. The mortality rate is about 2.1% per 100,000 treatment. So maksudnya sangat-sangat low mortality rate compared to other procedures. So these are the information that kita boleh bagi tahu patient ataupun family members untuk reassure mereka regarding the side effects. However, setiap procedure, setiap medication ada side effect dia. So what are the adverse events that can happen with ECT? Kita boleh bahagikan kepada during ECT ataupun post ECT. During ECT, there's a risk of oral injuries, cedera kepada kita punya mulut ataupun lidah ataupun gigi. There's a risk of prolonged seizure, okay? Dan there's a risk of cardiovascular effect, masalah dengan jantung, blood pressure semua tu. Kalau post ECT, adverse event dia termasuk somatic effect seperti sakit kepala, muntah, loya, ataupun cognitive effect memory macam kita panggil memory impairment ke ataupun delirium ke, dan juga hypomanic or manic switch. Kita akan pergi satu persatu. During ECT, adverse effect yang pertama adalah oral injuries. Contohnya kecederaan kepada kita punya lips, tongue, gum and even dental injuries. Ini adalah disebabkan oleh bila kita buat ECT kan. Kalau you pernah observe ECT, you akan perasan dia akan macam kejang. So due to clenching of the jaw from the direct stimulation of the muscle of mastication during the delivery of electrical charges. So mulut dia jaw akan jadi kejang. So kita boleh prevent by insert a bite block, correct position and placement. Okay, untuk prevent patient daripada tergigit sendiri punya lidah ke mulut ke ataupun gum to reduce injury. So this is preventable. Yang second, prolonged seizure. Apa maksudnya prolonged seizure? Prolonged seizure ada definition dia adalah sekiranya seizure tu lepas kita deliver electrical charges, dia akan berlangsung lebih daripada 3 minit untuk motor dan ictal manifestation. Maksudnya kita nampak pesakit sawan yang kita boleh nampak lebih daripada 3 minit. Ataupun kalau strict lagi yang definisi yang lagi ketat adalah more than 2 minutes from the ECT EEG recording. So maksudnya bila kita baca itu EEG tu yang nanti Dr. Chi akan jelaskan bagaimana kita untuk tafsirkan EEG reading tu. So if the EEG reading the seizure is more than 2 minutes, then it is considered as prolonged seizure. Kenapa dia boleh berlaku? Dia akan berlaku disebabkan pre-stimulus hyperventilation ataupun use of drugs which may reduce the seizure threshold. Okay, dan last kali, bagaimana kita boleh hentikan prolonged seizure tu? NS will provide IV benzodiazepine or even they prefer propofol to abort the seizure. So in terms of cardiovascular effect, kesan kepada jantung waktu ECT, kita boleh bahagikan kepada 4 phase. Immediately post stimulus, lepas kita bagi electrical charges, during the seizure, ataupun dekat dengan termination of seizure, ataupun post seizure. So kita kena bahagikan setiap phase of ECT dia akan ada sama ada sympathetic ataupun parasympathetic punya effect. Immediately post stimulus is parasympathetic effect. Semua benda jadi slow down right after kita deliver energy tu. So kita akan ada sinus bradycardia, jantung menjadi perlahan, hypotension, BP drop dan asystole. Okay, ini adalah disebabkan terutamanya lah lagi tinggi risiko untuk ada parasympathetic effect ni sekiranya pesakit ni ada unstable cardiac disease, they are elderly, there's hypoxia, there's subthreshold seizure, maksudnya seizure yang bagi tu tak cukup, ataupun bilateral electrode placement, which most of the patients we are providing bilateral lah for better efficacy. But don't worry about it, selalunya ini adalah akan spontaneously resolve selepas catecholamine release during seizure. So this is just temporary sahaja. Tapi kalau kita tahu pesakit ada cardiac disease, always avoid subthreshold seizure. Jadi selepas kita bagi stimulus, patient akan ada sawan, ada seizure. So during seizure is the other way around. Patient will have sympathetic responses. For example, semua benda jadi cepat, jadi spike up. Tachycardia, jantung berdebar cepat. Hypertension, BP jadi highish, or even to the extent of arrhythmia. Contohnya ectopic beats by Gemini, supraventricular tachycardia ataupun prolonged QTC. So these effects are from the anesthetic induction agents used during ECT. But again, usually it's just transient with spontaneous resolution. So tak payah risau banyak pasal yang ini. Dekat dengan termination phase pula, sekali lagi pesakit akan experience parasympathetic effect. Semua jadi slow down, bradycardia or even asystole. So we have to be careful about that. But of course, after post-seizure, dah habis seizure kan, so semua akan return ataupun reversion to the pre-ECT state. BP, blood pressure dengan pulse rate akan immediately return kepada pre-ECT state punya heart rate, normal heart rate lah dengan normal blood pressure. Kalau, sorry, bukan ECT, bagi ECG pula, ECG akan reverse after 30 minutes. Balik kepada ECG asal pesakit. ECG bukan ECT. Ya. So, yang tadi cakap tiga-tiga tu adalah adverse event during ECT. How about post-ECT? Post-ECT, the first one, which is the mildest one, usually sangat mild sahaja, adalah somatic effect. Yang selalu kita akan dengar daripada pesakit. Doktor rasa sakit kepala lah, rasa sakit badan, rasa loyak ataupun rasa nak muntah ataupun terus muntah. Ini kalau headache adalah disebabkan oleh contracture of our temporalis muscle and also masseter muscle during seizure. Masa kita jadi contract. Bila kita contracture, bila kita buat ECT. Kalau untuk myalgia juga, dia adalah use of muscle relaxant ataupun muscle fasciculation during seizure. Sebab tu akan sakit otot lepas tu. Dan kalau nausea dan vomiting, biasanya adalah disebabkan oleh sakit kepala ataupun adverse effect of our anesthesia punya medication. Okay, so apa yang kita boleh buat? Kita boleh rawat dengan menggunakan regular analgesic ubatan sakit, contohnya acetaminophen atau paracetamol ataupun antiemetic metoclopramide kalau serius. Yang kedua adalah hypomanic switch. So yang kita faham, kalau kita bagi pesakit inpatient with undetected bipolar depression, contohnya, kita bagi antidepressant, there's a risk of manic switch kan. Sama juga bagi ECT, ECT might cause manic switch in patients suffering from bipolar depression. So, apakah treatment recommendation dia? There are different school of thought, orang lain, study lain ada suggestion yang lain ataupun recommendation yang lain. Ada yang kata continue ECT sahaja sebab ECT ada mood stabilizing properties bagi pesakit yang ada bipolar. Ada yang cakap kita boleh withhold ECT dulu, kita observe for spontaneous remission of the manic symptoms dan lepas tu baru kita resume balik ECT. Tapi ada yang juga suggest kita abort ECT terus, kita start mood stabilizer, contohnya lamotrigine, carbamazepine ataupun sodium valproate untuk treat the bipolar depression. So different school, different thought depends on the practice and also the consensus from the discipline in your hospital. And the last one, which is the most concerning side effect by our patients and by our patients' family members, which is cognitive effect. Dan sebenarnya monitoring of the cognitive function is one of the KPI under national audit, which we need to do at least 3 to 6 monthly for all patients, especially those on maintenance ECT. So cognitive domain affected is mainly memory. So kita tahu cognitive function kita ada banyak jenis. Memory, attention, speed of information processing, executive function, general intellect, and etc. So, but the mainly cognitive that will be affected is memory. Others study have shown mixed results. So, kita tak boleh commit to it. So, what are the risk factors? Siapa yang ada risiko untuk experience cognitive side effect ini? Risk factornya termasuk bilateral electrode placement compared to unilateral, use of sine wave stimuli, use of stimuli with wider pulse width, high electrical charges relative to seizure threshold, closely spaced treatment interval. Maksudnya buat terlalu dekat, terlalu cepat. Increase number of treatment session. Of course, you buat 6 kali dengan 12 kali ataupun you buat acute ECT banding dengan maintenance ECT yang those with more numbers, more treatment session, you have a higher risk of adverse cognitive side effect. Ataupun concomitant drugs, for example, high lithium level, advancing age, elderly patients, and also pre-existing cognitive impairment ataupun neurological disorder. Contohnya stroke. Pesakit yang ada stroke already have the risk of having cognitive impairment. Kita buatlah ECT lagi, risiko dia lagi tinggi. Tapi it's not an absolute contraindication. We have to weigh the pros and cons of performing ECT and discuss with family members. So secara umumnya kita boleh bahagikan kepada 5 jenis cognitive side effects in post-ECT. Number 1, post-ictal disorientation. This is quite common. Usually transient post-ictal disorientation maksudnya dia jadi confused lepas buat ECT. Biasanya transient immediately post-ictal. could be just few minutes, could be few hours, depending on the recovery, how fast the patient recover from that. Sebab tu kalau kita pernah observe, lepas buat ECT, pesakit akan nampak macam confused sikit, blur-blur macam tu. So this is actually due to post-ictal disorientation. It is often associated with amnesia. Dia pun lupa tadi dia buat ECT contohnya. So correlate with retrograde memory impairment if it become extensive and persistent. And treatment, biasanya tak ada apa-apa treatment diperlukan, cuma reassurance and also avoid cognitive demands in those patients. Next one is post-ictal delirium. So dia jadi confusion yang lagi panjang. Okay, lagi lama. Patients biasanya become restless, aggressive, and agitated after buat ECT. Risiko what are the risk factors? Elderly patients, concomitant drugs, for example, sedative, antipsychotic, anxiolytic, and also lithium use, or type and dosage of anesthetic agents, ataupun prolonged seizure. So this will increase the risk of post-ictal delirium. So what are the treatment? Again, supportive management and reassurance. Tapi sekiranya restlessness, aggressive, and agitated is too unmanageable, we might even consider IM antipsychotic. Even though the guideline did mention about IV benzodiazepine, but it has to be used with caution because benzodiazepine can cause further confusion as well. It is also advisable to do EEG monitoring to rule out subclinical seizure activity. So kita terus monitor juga in case kita miss out the seizure is actually still ongoing and the delirium is directly due to the seizure, during the seizure. Next one, anterograde memory dysfunction. Maksudnya, pesakit akan ada masalah untuk belajar benda baru, ingat benda baru selepas ECT, especially verbal learning. Most consistent cognitive adverse effect. So ini yang paling well established lah. But this usually is just short term, unlikely to be long term. Usually it will self-recover after days or months. Maksudnya lepas tu dia macam susah nak ingat benda. Okay? So tapi tak apa, just reassure mereka self-recovery will happen later after days or months. Another one is retrograde memory dysfunction. Maksudnya banding dengan anterograde yang susah nak belajar benda baru, retrograde maksudnya susah nak ingat balik apa yang berlaku sebelum ECT, especially previous learned information prior to ECT commencement, especially autobiographical or impersonal memory domain. Lupa apa yang berlaku sebelum ECT, apa yang berlaku sehari sebelum ECT contohnya. So this is due to residual difficulty. Mereka akan experience residual difficulties with patchy memory traces. Macam ada, macam tak ada, they can't really recall. So treatment, it will improve substantially with time, and self-recovery is expected. However, it is slower than anterograde memory dysfunction. So we have to reassure patients regarding that. And the last one, the last cognitive effect is actually subjective memory loss. Maksudnya, lepas buat isu, patient akan selalu complain, saya rasa saya semakin forgetful. Susah nak ingat, memory jadi tak bagus for years after ECT. It's very subjective sebab bila you buat objective neurological test, contohnya bila you buat MMSE ataupun MOCA, score high marks ataupun full marks. The reason is, there are few reasons to explain that. It could be due to the residual symptomatology or the comorbid brain disease. I mean symptoms of the illness itself, residual symptoms. We have to understand that schizophrenia, bipolar, or even depression also, cognitive impairment is one of the symptoms. So this could be the symptoms of their illness itself, or they actually have comorbid brain disease, which we need to work out. It could be due to the medication use or substance use, comorbid substance use that cause the cognitive impairment. It's multifactorial to contribute to a cognitive impairment. It could be sensitization to normal forgetting. That means that it's just normal forgetting process, but patient become hypervigilant and become very sensitive about it and very concerned about it. It could be a conversion symptoms or secondary gain. Contohnya, they are actually asking for SOXO or something. So we have to rule out that kind of possibility. It could be due to deep-rooted negative expectation of ECT. Bila cakap pasal ECT, straight away associate with memory impairment. forgetfulness, dementia, or something. So this deep-rooted negative expectation will make them even convince them that the normal forgetting process is actually a side effect from ECT. And the last one, it could be the real neurobiological effect due to ECT, but not being able to be detected by our current neurological testing, not being picked up by our MOCA ataupun MMSC, which are the two most common neurological tests. Again, we'll try to avoid by the measures that I mentioned earlier, and also reassurance for the patient. And lastly, let us discuss about what are the pharmacotherapy used in ECT. Okay, we are focusing on our psychotropic medications and also our non-psychotropic medications. In general, antipsychotic should be continued during ECT because they have this synergistic therapeutic effect. So bila kita teruskan antipsychotic dengan ECT, patient akan lagi sembuh, lagi cepat dan lagi efektif kalau kita combine dengan ECT. So semua antipsychotic kita terus continue sahaja. For antidepressant, depends on what antidepressant patient is on. Kalau patient is on SSRI, mirtazapine, or even the older generation one, tricyclic antidepressant, continue sahaja. Kalau untuk duloxetine ataupun agomelatine, so far tak ada available recommendation, so continue shouldn't be a problem. However, if patient is on venlafaxine will cause ventricular tachycardia, especially during sympathetic surge during the seizure. So we have to keep the dose of venlafaxine lower than 200 to 300 mg per day, don't more than that. If patient is on MAOI, so MAOI is associated with hypertensive crisis during ECT. So the recommendation is to stop 24 hours prior to ECT. Wash them out first before kita startkan ECT. Okay, so for mood stabilizer, we have two types, either non-lithium ataupun lithium. Non-lithium maksudnya sodium valproate, carbamazepine, lamotrigine. In that case, because we know that those non-lithium mood stabilizers, a lot of them are actually anti-epileptic agent as well. So we need to reduce the seizure. They will reduce the seizure duration. Okay, they will increase the seizure threshold. So therefore, we have to stop or half it and withdraw over a week before kita start ECT. Sebab tu patient yang ada bipolar disorder, we will off the mood stabilizer if possible, so before we commence ECT. The next one is lithium mood stabilizer. So also for non-lithium mood stabilizer, there's a consideration of giving got confused. All right. So the next one would be lithium mood stabilizer. For lithium mood stabilizer, lithium would cause confusion and delirium, especially in elderly. So because of that, we need to discontinue at least 48 hours prior or to maintain at the lowest therapeutic lithium level during ECT to avoid the side effects of confusion and delirium. We also have to ensure adequate hydration for patients who are on lithium as their mood stabilizer as well. For benzodiazepine, we know that benzodiazepine will increase the seizure threshold and reduce the seizure duration. It is also acting as an anticonvulsant. Therefore, benzodiazepine should be stopped or used at the lower dose, or even we convert it to shorter half-life. For example, lorazepam instead of using diazepam. Okay, or we change it to the Z drugs, zolpidem. Okay, or another one, we have to give higher stimulant dose if we cannot stop the benzodiazepine at all due to the very severe destructive behavior in the ward. So we need to give higher stimulus dose, or we will use bilateral ECT. Also, we actually can give IV flumezanil during the ECT course as well, as an antidote for the benzodiazepine, so that we can get a better outcome from the ECT that we are performing. For other psychotropic drugs, acetylcholinesterase inhibitor is allowed to continue during ECT. Methylphenidate otherwise didn't have any recommendation on that. What about patients' other medications for their comorbid for their comorbid medical illnesses. For antihypertensive, they should be just continued. But those antihypertensive can be served before ECT because we want the blood pressure to be optimized before the ECT, as mentioned earlier, to prevent hypertensive crisis during ECT. But we are aware that patient has to be kept nearby mouth as well. So kita bagi ubat antihypertensive with sip of water. Kecuali diuretics. If diuretics, kita kena serve lepas ECT. Okay. Theophylline, as mentioned earlier, if it's being used in COPD or even asthmatic patients, consult the respiratory physician. We have to taper off or even substitute or keep it at the lowest dose. Okay, anti-gastric just continue sahaja, antacids and also a proton pump inhibitor. Just continue that because this will even reduce the risk of aspiration, especially in patients who are obese. For anti-diabetic, whether it is OHA, oral hyperglycemic agent, or insulin, we try to serve it. We try to perform ECT early in the morning. We don't want patient to fast so long, and we will serve the anti-diabetic post-ECT and pre-breakfast. Warfarin, consult the physician. Usually, we can continue if there's no contraindication, but they need, the INR needs to be kept lower than 3.5. If patient is on anti-glaucoma, as mentioned earlier, which will increase the intraocular pressure, consult ophthalmologist. Okay, usually we need to serve it prior to ECT. So basically, that's all for my presentation. My reference would be, as I mentioned earlier, is basically from the guideline of electroconvulsive therapy for Ministry of Health Basis, Practicality and Policies, which is published in 2021. We can, you can, if you're not familiar already, you can always download it when you Google it, or we can even provide the link later for you to download it and have a look. It will be more comprehensive in that. And with that, thank you.
Okay, terima kasih Dr. Tan Kaipin atas ceramah yang telah disampaikan sebentar tadi. Jadinya daripada ceramah dua topik tadi boleh disimpulkan yang ECT ni sebenarnya selamat untuk dijalankan di bawah pengawasan dan kena mengikut guideline yang telah ditetapkan. Dan kita sebagai perawat, terutamanya doktor lah kan, sebab kita nak kena minta consent sebelum ECT. Apa yang telah disampaikan tadi, apa itu ECT, indikasi ECT, adverse effect atau kesesampingan ECT, yang itu semua perlu beritahulah kepada pesakit dan kepada keluarga sebelum kita decide untuk buat ECT itu sendiri. Okey, jadi sekarang sudah pukul 9.30. Kita akan ambil masa lebih kurang 15 minit untuk sesi rehat dan kita akan kembali semula pada pukul 9.45 pagi nanti. Pada waktu rehat ini, para peserta bolehlah scan QR code kehadiran MMA dan MyCPD yang akan dipaparkan sebentar lagi. Okay, jadi kita akan sambung semula pada pukul 9.45 pagi. Boleh? Jawapan boleh.
Screenshot lah.
Ya, ya. This one. Yang mana tak boleh? Nama Insta macam
Assalamualaikum dan selamat kembali kepada semua peserta bengkel. Diminta semua peserta untuk bersedia untuk sesi kita yang seterusnya, ceramah nombor 2 bersama dengan Dr. Chi Jun Heng. Okay. Yang untuk scan kehadiran MMA dan MyCPD, saya harap dah tak ada masalah. Tapi sekiranya ada masalah boleh ditulis di chat box dan kita akan cuba untuk tengok macam mana selesaikan. Okey, jadi bengkel kita pada pagi ini diteruskan lagi dengan sesi ceramah daripada Dr. Chi Jun Heng yang akan menyampaikan ceramah yang bertajuk Electrophysiology of ECT dan Placement of ECT Electrodes. Sedikit pengenalan berkenaan dengan Dr. Chi. Dr. Chi merupakan graduan daripada Royal College of Psychiatrists UK. Beliau sekarang berkhidmat sebagai pakar psikiatri di Hospital Tengku Ampuan Auzan dan beliau merupakan penyelaras jawatan kuasa ECT HTAA. Beliau aktif dalam pelbagai organisasi dan telah menyertai pelbagai conference dan membuat presentations. Dengan segala hormatnya, saya ingin menjemput Dr. Chi untuk menyampaikan ceramah beliau. Persilakan Dr. Chi.
Hai, selamat pagi semua. Saya Dr. Chi. Jika connection ada
Maaf Dr. Chi, sorry, tak dengar suara.
Sekarang dengar tak?
Tak dengar.
Oh. Sekarang dengar tak?
Tak dengar doktor. Sekejap doktor. Alright. Boleh. Okey, boleh doktor. Cuba try.
Orang lain dengar tak?
Okey, boleh.
Boleh. Okey. Alright, thank you. Okay, selamat pagi semua. Saya Dr. Chi, pakar psikiatri HTAA. So today I have two topics. One is the electrophysiology of ECT. I think I'll present that second. I will present about placement of ECT electrodes first. Okay. First, I need to apologize. I am not feeling very well. If I'm not speaking very clearly, please let me know. And yeah. Okay, and I would also like to thank Dr. Khalil for joining us today. Dr. Khalil, neuropsychiatrist from HSNZ Terengganu. Okay, so let's start with our first topic, okay? Okay, so let us begin with the first topic, placement of ECT electrodes. Okay, this is our beautiful HTAA against a blue sky. Okay, last few months we haven't had this kind of weather. Okay, my slides will mainly have a lot of photos, so don't need to take a lot of notes, just look at the photos that I'll be showing, okay? All right, this is the outline of my presentation. First, we'll talk about placement of recording electrodes. And then placement of stimulus electrodes. Okay, so where does the ECT record to show the EEG trace? And then next, where do we provide the stimulus of the electrode? Okay, for placement of stimulus electrodes, there are 3 ways we can do it. It is by bitemporal, bifrontal, and also right unilateral ECT. Okay, and finally, we'll talk a bit about the differences between bilateral and unilateral electrode placements. Okay, so placement of recording electrodes. Okay, recording electrodes provide a visual tracing for the ECT seizure and also for us to look at the characteristics of the seizure activity. ECT-induced seizure, it is best when we record from frontopolar areas to the mastoid area. Okay, the mastoid region, it has the least, it is the one that doesn't move the most, it is most electrophysiologically inactive. So it is a very good point of reference for us. Okay, and so this is the way that we prefer to record the electrode, the way we record our EEG tracing. Okay, so where is the placement of recording electrodes? Okay, remember it is, if you look at this picture, it is between our eyebrows. We find the midpoint, okay, on both sides. And then it is just perpendicular to the eyebrow at around 1.5 cm above. Okay, this is for the frontopolar electrode. That would be, for me, it would be 1 finger above my eyebrow. Okay. For the mastoid electrode, we just have to find the most bony prominence on the electrode. I'm sorry, on our skull, and then we place the electrode there. Next, we will talk about the placement of stimulus electrodes. Again, there are three types of way we can put the stimulus electrodes: by temporal, by frontal, or by right unilateral stimulus electrode. So most commonly, we use bitemporal. I think throughout Malaysia, all hospitals, psychiatric settings will be most familiar with the bitemporal method of placing the electrodes. But I think it's important for us to also understand when should we use bifrontal, and when should we also use right unilateral ECT, so that when we know more, then we can help our patients better by different methods. Okay, so 2 types of stimulus electrode placements. Bilateral, we have bitemporal and bifrontal, as well as unilateral, which is typically placed on the right side. Okay, so for the bitemporal stimulus electrodes, okay, if you see the letter T on the diagram, T is where the electrode is placed. Okay, so first we identify the external canthus, that is the corner of our eye. Okay, and then we find the tragus. Okay, if you can see, this is the tragus. Okay, not the pinna. Okay, not the earlobe, is the tragus. Okay, so we identify the corner of the eye, the external canthus, and also the tragus. We draw an imaginary line, okay, across, and then 2.5 cm perpendicular to that above. That is where our temporal is. This is where we place our electrodes. For me, that's around 2 fingers above lah. When I draw the line from the tragus to the corner of my eye, around 2 fingers above. Okay, so that when we place the electrode, especially when we place either the metal kind or the sticky pad, we want to find the center of that pad to place on the spot that is marked as T. Okay. For bifrontal stimulus electrode, it is not very commonly used actually. So it is nice to know, good to know, but not a must know, I will say. Okay. If today you go home after this lecture, if you only know bitemporal, if you know how to put your recording electrodes, I'm very happy already. Okay. But for bifrontal, we find the parasagittal planes, which is macam ni lah, the line that slices the brain this way. Okay, we put that at around the external canthus of the eye, again the corner of the eye. All right, and from the corner of the eye, we find the spot which is 5 cm above. For me, that's around 3 fingers above lah. Okay, so 3 fingers on both sides. Okay, it should be around 10 cm apart. Okay, and then that is where we put the bifrontal stimulus electrodes. Okay, I will talk a bit about why we choose bifrontal later. Okay. So, sorry, when we put the bifrontal stimulus electrodes, it will be on the outer side, okay, it will be above the external canthus of the eye. So the the recording electrode, the one that reads the EEG, it will be placed here in between, okay? So here in between, and then here are the stimulus electrodes for bifrontal. Okay, the third method is right unilateral ECT, or we place it on the temporoparietal electrode placement location. Okay, it's also called DELIA. Okay, so for the right side of the temporal electrode, it is just like bitemporal. Again, between tragus and the corner of our eye, we draw an imaginary line. We find the midpoint, and then 2 fingers above, that is where we put the electrode for the temporal side. Okay, but for the one on the parietal region on top of our head, okay, we have to find the nation and union of the skull just means that, of the head, just means this point between our eyes where the nose connects to the face. So this point is the nation. Okay, we find this point, trace it all the way to the back to find the occipital protuberance, the most prominent point of the occiput. Okay, when we trace this line and we trace 2 lines across the tragus, then there will be intersection. Okay, when we find the intersection point on top of our head, we go lateral towards the right side, 2.5 cm. Okay, so around 2 fingers, and that spot is where we put the parietal electrode. Okay, and this is for right unilateral ECT. Right unilateral ECT, still 2 electrodes needed, but both are on the right side of the brain. Okay, and why we do right unilateral ECT? It is because we are looking at where is the dominant hemisphere of the brain. For most people, they are right-handed. Then they will have a left dominant hemisphere. Okay, but for people who are left-handed, 90% are also having a left dominant hemisphere. And so it makes sense for us to put it on the right side. Okay, when we stimulate, we provide the ECT from the right side, we reduce the risk of cognitive side effects for this group of patients. Okay. Okay, so we talk a bit about the differences between bilateral and unilateral electrode placements. For the bitemporal, of course, it stimulates from the stimulus is given from the temporal lobes. For bifrontal, is from the frontal. I think that's self-explanatory. For unilateral, we do it on the non-dominant temporal and parietal lobe. So most of the time, it's more than 90% of the time, it is on the right side. Okay. Bitemporal is what we always do in most hospitals in Malaysia, because it gives us the fastest response. Usually, as Dr. Tan has already mentioned earlier, we want fast response for our treatment for our patients. So the patients who are actively suicidal, the patients who are catatonic and don't want to eat, we want to see very fast response for this group of patients that are at the highest risk. So that's why we do bitemporal electrode placements. Bifrontal is used because some group of patients with any heart conditions, such as arrhythmia, such as IHD, bifrontal has been shown to have less instances of asystole during ECT stimulus. And also there are less severe episodes of bradycardia. So for certain groups with heart conditions, we can consider bifrontal. Otherwise, the efficacy between bitemporal and bifrontal is the same. Okay. For unilateral, when we place it on the right side, the temporal parietal placement of the electrode, it is best for people who need the cognitive advantages, who cannot have the cognitive side effects of bitemporal electrode placements. Okay, so those who are very susceptible to delirium, those who already have dementia, those who in the past, when we do bitemporal ECT, they have very severe confusion, very prolonged delirium after the ECT, then we should consider doing right unilateral ECT for them. Okay, and when do we consider switching from unilateral to bilateral? Actually, it's quite simple. It's just that when we do we do bilateral, and then the patient suffers from a lot of confusion, a lot of cognitive side effects, then we consider unilateral. Okay, and vice versa for those where we start right unilateral, if they do not respond fast enough, if we are starting right unilateral ECT for high suicidal risk, for example, but we do not get the response that we want, the patient after multiple sessions still has active suicidal ideation or plans, then we consider to switch to bilateral instead, because this is all about weighing the risks and the benefits, right? And the ECT efficacy for right unilateral is supposed to be the same as well, but they need a higher dose. So when we adjust the energy of the stimulus that we give, unilateral typically needs a higher dose compared to when we give bitemporal. Okay, so bitemporal, typically we start 5% for females, 10% for males. For unilateral, you may need to multiply that. It should be higher. And I believe Dr. Kale will mention more about this later. Okay, so in terms of the side effects, of course, bitemporal has the most side effects, cognitive side effects. Bifrontal slightly lesser than bitemporal, and right unilateral has the least. Okay, when it comes to other side effects like headache, nausea, muscle pain, this is the same across all types of ECT. So the stimulus electrode placement will also affect the impedance. Impedance is, for those who are familiar with the Timertron machine, there is, so yeah, for the question in the pre-test, the last question, the answer to which ECT machine we use in HTAA, it is Timertron, not Dynamo, okay? Impedance is the resistance to the electrical current due to presence of skull, soft tissues, and skin, whatever that prevents the electrical stimulus to reach the brain, okay? It shouldn't be too high, it shouldn't be too low. When there is a problem with the cable, maybe connection is not good, it's usually more than 2,000, 3,000, okay? That implies that the resistance is too high because it cannot pass through the cable, okay? If there is poor scalp preparation, for example, maybe the patient's hairline is quite low. So when you identify the place to put the bitemporal electrode, it is on the hair, but without, maybe you need to shave a bit. Without shaving, there will be poor contact, and that's why the impedance will be high, okay? But when the stimulus electrodes are too close together, the impedance will be low instead, okay? Or there are other things that disturb, like sweat and too much of gel, for example. So it's too slippery, yeah. And then so sometimes the impedance will be too low as well, okay? So to sum up this first presentation, these are some of the key points. Recording electrode placement, we prefer frontal to method, okay? And then we have three types of stimulus electrodes: bitemporal, bifrontal, and also right unilateral, okay? Bitemporal ECT is administered when we need rapid clinical response in patients who had previous good response to bilateral ECT, and also the patient's preference. Bifrontal we use in those who have had ischemic heart disease or any arrhythmia. And unilateral ECT we use for the cognitive benefits in patients who are susceptible to delirium, to confusional states, okay? Efficacy of unilateral ECT is comparable to that of bilateral, but you need a higher dose, okay? So 5% for bitemporal is not equal to 5% for right unilateral, okay? And finally, the proper placement of stimulus electrodes is very important so that we prevent high impedance. If not, the stimulus cannot be delivered. Okay, so these are my references. Okay, thank you very much. I shall move to the next presentation. Oops. I have to turn off. This is it. Then I go to this now. Oh, am I sharing the right screen? Okay. Okay, can I move on to the next presentation? Okay, next we talk about the electrophysiology of electroconvulsive therapy. Okay, big words, but again, minimal words in my slides. I want you all to look at the pictures rather than focus so much about taking notes. Okay, I know some of my MOs are very good taking a lot of notes inside the Bilik Mutiara. Yeah, not needed. Focus on the picture on the screen. Okay. Here. So this is our outline for the second topic. We will talk a bit about electroencephalogram and EEG in ECT. We will highlight the 5 phases of the ECT EEG recording. Okay, and this is how we interpret the EEG when we do the ECT and it comes out. Okay, and artifacts lah, all these things that catch out our ECT. How do we identify them? How do we reduce it so that we can have a good tracing? Okay, and then we will look through a few cases later. Okay, so electroencephalogram, it is a voltmeter. It just detects volt. Okay, big words again. It detects the summation of fluctuating electrical field potentials, which are generated by excitatory and inhibitory postsynaptic potentials. Basically, it is just picking up our positive potential against negative potential from one electrode to the other, and then it will show the results. Okay, just like any other voltmeter like ECG, just the same concept. Okay, when we are looking at EEG in ECT, we want to look for epileptiform discharges because ECT is inducing a seizure, am I correct? And in epileptiform discharges, we need to be familiar with a few types of waves, which we will see in the ECT EEG. Okay, for example, spikes are fast waves. They look very spiky, as explained by the name spikes. Okay, and polyspikes are when a group of them are placed together. Whereas slow wave, they're more prominent. They have high amplitude, low frequency. These are certain terms that we should be familiar with when we look at the ECT EEG, and also how to determine the termination. Okay, so these are some examples. Okay, polyspike, you can see it is high frequency, low amplitude, and you can see it's very spiky in appearance as compared to the spike and wave complexes. Okay, there is a spike, it comes down. There's a small spike. Okay, it's slow wave, the amplitude is big, but the frequency is lower. Okay, in polyspike and wave, you will see the frequency is a bit higher, but actually overall, because like we said, the voltmeter, the EEG, it takes into consideration plus and minus, right? So when you see prominent slow waves, the amplitude will still be high and the frequency will be lower. Okay, if anybody has any questions, can place in the chat box later. Okay. All right, so EEG in ECT, it is quite common to see that if for people who have done ECT frequently, you will see that one patient's ECT and another patient's ECT looks very, very different. So it is actually very common to see very different epileptiform discharges from one ECT to another. And it is even common in the same patient. You do one session, it looks like this. The second session, it looks a bit different. Okay. So usually our difficulty is not in trying to identify, oh, has the ECT taken place or not? The difficulty is when we don't know how to interpret, is this ECT good? Or is this ECT actually not good enough? Does this ECT, this session, does it bring about clinical benefit that I want to see in the patient? Or do I expect that actually this ECT is not good enough? I need to make adjustments. I need to adjust the energy of the ECT. I need to look through the medication list to see whether anything is affecting my ECT. Okay, so next we talk about the phases of ECT EEG recording. Okay, so these are the 5 phases of ECT EEG recording. First is recruitment, followed by polyspike with slow wave complexes, termination, and finally the immediate post-ictal phase. Okay, this is typically how after we press the button and we deliver the stimulus, this should be the EEG that presents itself in the strip. Oh, sorry. Okay, so if we look at this, okay, this looks like a good ECT, right? Okay. When we look at the recruitment phase, that is identified by the red arrow, followed by polyspike phase, which is indicated by the yellow arrow. And then the brown arrow shows us the slow wave complex phase, and pink arrow, termination phase. Okay, when you see termination, it is not so organized. And finally, the immediate post-ictal phase. Okay, so let's run through them one by one. Okay, first is recruitment. Recruitment phase is after you deliver the ECT. When you press the button and you hear the sound change, okay, you release the button, then you will see the recruitment phase. Okay, usually there is a slope that goes up, which indicates the stimulus has been given, and then it goes into recruitment phase. Okay, it is very low amplitude. The frequency is high. It is always before it evolves into polyspikes. And during this time, usually we don't see any movement, no motor convulsions seen in the patient. Okay, so for the people who are taking the time, maybe they won't see convulsions at this point. And so this is typically why when we take our ECT seizure duration compared to our motor seizure duration, the ECT seizure is usually a bit longer. Okay. It is important to know that sometimes the recruitment is so fast that in our strip, in our calibration, we don't even detect it. Okay. So if it is not there, but you get a good trace after that, it's a good sign. Okay. Don't look for it so much, and then you miss the following waves that come. Okay. So if we look at this from 0 second to 6 seconds, okay, and then if you compare, if you block off 0 to 6 seconds and then you block off 6 onwards to 10 seconds, you will see that it's actually different. Okay, sometimes it can be quite difficult to determine where is the changing point, but remember, recruitment is low amplitude, high frequency, and then you should see that it becomes more characteristically polyspike later on, and that's how you identify where it ends. Okay. So again here, this is from the first figure that I showed earlier. Okay, if you see from 0 to 4 seconds, it is a high frequency, low amplitude, but then later on it becomes, the frequency is even higher. The amplitude is slightly bigger from 4 seconds on. So this is where we know that the recruitment has reached 4 seconds and then has moved into the polyspike phase. Okay, next we look at the polyspike phase. This is compared to earlier. Earlier was low amplitude. Polyspike is higher, not very high, but higher amplitude, higher frequency. And it is during this time that we see the patient going into tonic phase. Okay, so motor seizures, when you observe the tonic convulsions at that point of time. Sometimes it is also absent in ECT traces. When it is so fast, the ECT is so effective that it goes straight into the polyspike, and that's when it is not apparent inside our calibration of the ECT EEG strip. Okay, so if we look at this figure 2.2, this is from 4 seconds up till 12 seconds. This is when we see higher amplitude, higher frequency, but the amplitude is not as high as the polyspike, sorry, not as high as the slow waves later on. Okay. Then we look at polyspike with slow wave complexes. This is a regular pattern of polyspike and slow wave. It is a combination. Okay. Sometimes we only see slow waves as well. Sometimes we don't see a lot of the spiky appearance in the slow waves. It is high amplitude, but the frequency is lower. Okay, and this is when we observe the patient, it goes into clonic phase. Okay, that's when they will convulse. Okay, so if we look at this figure, you will see that from 12 seconds all the way until 29 seconds, you will see it is all high amplitude combined with a bit of polyspike. Okay, high amplitude and also slower frequency, reduced frequency, and this is the slow wave complex that we want to identify. And slow wave complexes are very important to identify because that is the part where it translates to a good ECT. When your slow wave isn't very good, maybe your ECT isn't very good. When your slow wave is very cantik, then more likely than not, your ECT will give you good results. So you will see the clinical benefit in the patient. Okay, so after it completes the clonic convulsion, then usually it will terminate. So the seizure may terminate very abruptly. If you look at figure 4.1, you see, suddenly it just goes into almost like your baseline kind of look. Maybe even it terminates so abruptly that you don't even see that baseline activity. It becomes very minimal activity. But the problem is termination is not always so well behaved. Sometimes they want to terminate in a very different way. They terminate very gradually. The slow waves become, the amplitude becomes lesser, it becomes disorganized. You can't really tell, is this still slow wave or actually is it terminating already? So if you look at figure 4.2, unlike figure 4.1, very cantik kan, it goes right into like a baseline kind of tracing. If you look at this one, figure 4.2, it goes on for quite long, and then the amplitude becomes smaller and smaller. The frequency is also not so regular. So for a trace like that, the termination is still ongoing probably until 60 seconds. If you can see the last bit of the strip there, yeah, that is probably where it finally terminates properly. Okay. The termination probably starts from 36 seconds, I will say. Okay, up to 35, it is still a slow wave. Then 36 seconds onwards, then it becomes more and more disorganized. Okay, but we don't call this disorganized phase, we just call it termination phase. Okay, if we look at figure 4.3, it's the same. Okay, previously you see the slow waves very well behaved. That is indicated by the brown color line, right? If you see here, okay. But when it evolves to the termination phase, then it becomes the amplitude reduces, frequency also reduces, not so regular. Okay, so this one is also a progressive change into the termination phase. It goes on up till 42 seconds. Okay, and finally you go into immediate post-ictal. This is a refractory period, so you actually expect the activity on the EEG trace to be even lesser than baseline. Okay, but it's sometimes quite difficult to determine where it ends actually. So for example, if we look at this, figure 5.1, you will see that the strip above is the baseline. Okay, and then when you see figure you see the figure 5.1b, the end of the seizure is very clear. Okay, there is even less activity than compared to the baseline. So this is a very clear immediate post-ictal phase. But sometimes it's not so clear. Okay, you go back in this figure 5.2, you will see that the baseline has a bit of activity. When you look at the second picture, the strip on your right lower corner, it's not very clear. The endpoint isn't very clear. And that's also okay. It doesn't mean we cannot interpret the EEG. Okay, it means that it has ended, but we just cannot identify the clear post-ictal phase. Okay, if we look back at this one, we will see that after 41 to 42 seconds, there is a suppression. Okay, so this is the post-ictal phase, post-ictal suppression phase. Okay. Okay, so coming back to this is the entire strip that we've seen before, and then we've broken it down to every phase, how it should look like. Okay. So here's a recap. 5 phases starts with recruitment. Recruitment is low amplitude and high frequency, followed by polyspike, which is higher amplitude and higher frequency, followed by polyspike with slow wave complexes. High amplitude, sometimes frequency can be lower. Okay. Amplitude means how high it is, yeah, from the peak to trough. Okay, and frequency is how many spikes there are. Okay, and then it moves into termination phase, and finally the immediate post-ictal phase. Okay, so artifacts are just this little disturbance lah, gangguan in our EEG strip. Okay, so let's look through some common ones. Okay, the EEG will definitely detect any electrical activity it can besides the brain. And then this one will disturb our EEG recording. Sometimes it makes interpretation very difficult. Okay, so if we look at this, number one, this is a physiological artifact. If you look, it looks quite regular. You're not too sure what it is. When you see this on the EEG strip, sometimes you have to look at the patient, look at the patient's face, the head, to see whether there is any possible contributing factors. Okay, so this one is actually jaw tremors. So this is the patient's baseline, but the patient has jaw tremors. So maybe only after the anesthetist gives the muscle relaxant, maybe then we should do the baseline again so that we can get a good baseline. This kind of a baseline, sometimes our PSI, our adequacy will not be very accurate. Okay, next, this is another type of physiological artifact. Looks quite regular. It's actually voluntary eye blinking. Okay, so if I attach an EEG to any one of you, and then we ask you to blink your eyes at regular intervals, it will look like this as well. Okay, there's always an upward deflection, then downward deflection. Okay, so if the patient is blinking and then we do our baseline, it won't look very nice. It will disturb our interpretation as well. Okay, next, if you see the physiological artifact here, it is very regular. Okay, not so much in the second EEG, but on the first EEG, you can see it is very regularly spaced. Okay, and so this is actually the EEG recording electrode, which is on your frontopolar and your mastoid area. Maybe the mastoid electrode is placed a bit low. And so actually it is also detecting the carotid pulse. The carotid pulse that goes up, it's detecting it. And that's why we see this regular pattern of the pulse. Okay, if you compare, usually your EEG will also come with your ECG below. You actually see it corresponds. This is a very common artifact. Okay, and next we see extra physiological artifacts. Okay, when you see this, you shouldn't be frightened. This isn't a right-sided ECT or anything like that. Okay, always when you see anything that does not look normal to you, that's when you want to troubleshoot. Okay, and this is actually very simple. It's just that the electrode has come off. Yeah, and it's only on one side. Okay, when it's one side, you probably suspect, yeah, electrode has come off. If it's both sides and it looks like that, maybe the electrode that connects to the machine has come off. Okay, so let us look at a few cases now. Here, case number one. If we look at this, how can I make this interactive? Can we try to look at case number one? And can somebody just shout out in the chat group? Recruitment is from how many seconds to how many seconds? And then polyspike is from how many seconds to how many seconds? And then polyspike and slow wave complexes, followed by termination and finally post-ictal suppression. I will give you 2 minutes. If I don't get any answers on the chat group, then I will point out people to answer. Okay, any answers? Let's see. Okay, Dr. Siti, thank you very much. Recruitment up to 5 seconds. Let's see if that is correct. Okay, I will say it is. It is slightly lesser than that. If you block it off, you will see, if you compare 1 second by 1 second, actually the low amplitude changes into higher amplitude and higher frequency at around 3 seconds. Yeah, thanks for your answer. Thank you very much, Ramat. Okay, the next phase, anyone want to try? This is just a practice session. Yeah, don't have to be worried about identifying the wrong parts. Maybe let's see. Dr. Nick, can you try to identify the polyspike phase from what second to what second? Okay, tak ada. Okay, never mind. I shall. Okay, 3 to 10 seconds. Polyspike 4 to 12 seconds. Ramat, thank you very much. Yeah, I agree with you. I think that the polyspike moves from around 3-4 seconds all the way to the 12 second. Okay. Yeah, the reason why we place it at 12 is because later on the amplitude starts to increase a little bit. Okay, sometimes it is not very clear, but it's okay. We interpret case by case, right? So we place it at around 12 seconds. That is when the amplitude starts to become bigger. Of course, it only becomes classically polyspike and slow waves at around 20 seconds onwards. Okay, at first it's still a combination. Okay, so the next phase, polyspike and slow waves, it goes all the way until here. Actually goes all the way until 29 seconds. Okay, this part it is starting to become more and more disorganized, but to me it still looks like slow waves. From 29 seconds onwards, then it becomes less regular. The amplitude changes, there's less frequency, and also then it becomes more and more disorganized. Okay, so here, yeah, Ramat, again, I agree with you, slow waves around until 28-29 seconds. Okay, and then the next part, Ramat, maybe you want to try to answer, where does the termination go from 29 seconds until? Yep, 37 is correct. Okay, yeah, from 37 onwards, then if you compare with the baseline, actually it has less electrical activity than the baseline, which is on your left upper corner. Okay, thank you very much. Yep, I agree with you. From 37 onwards, it's post-ictal. And then after a while in the post-ictal suppression phase, you expect it to go back to a bit more like the baseline. Okay, all right. Next, let us look at the, I have videos as well. I think that's more representative. But let's look at this other photo first. Okay, this is the second case. This is the baseline that we've done for the patient. Okay, if you can see, there is a bit of activity, but it's quite okay. It's acceptable. All right, and this is also, this is one of our cases that we did in HTAA. Okay, and then this is how it progresses. If you see here, actually, you cannot really identify the recruitment. Okay, it is quite fast. It's probably less than 1 second. Okay, by this point, it looks a bit like a polyspike already, even at 1 second. And then subsequently, you see that the amplitude is actually already quite big. It's quite regular. Frequency is lesser than what you would expect in a polyspike. Okay, so actually, here I would say the recruitment is definitely probably less than even 1 second. Okay, same with the polyspike. And from 2 seconds on, you can clearly say it is already in the polyspike slow wave complex. Okay, and then it runs all the way. If you see both EG1 and EG2, right and left, all the way until probably around 32 seconds. Okay, and then it becomes a bit less organized. So this is then the termination phase. Okay, and from 32 seconds until 37 seconds, termination, and subsequently, of course, the strip is not long enough for me to show you, but then it goes into the, oh wait, sorry, I think I have the next part. Yep, here. So from 37 seconds onwards until 47 seconds, it's already in the post-ictal, the immediate post-ictal phase. Okay. All right. Next is a video. Okay. It's taken very slowly. I hope it's clear enough on your side. Just have a look at how it progresses. So when we see a still image of ECT, EEG, sometimes it's hard to interpret even when it is still. So there are a lot of quick judgments we need to make while the EEG is ongoing. Okay, whether you want to titrate the dose further, whether this is good enough, or whether you want to stop. At the same time, you have to check with NS. So it's a lot of multitasking in that few minutes. Okay, so I think it's good practice to look at videos as well. Okay, so let us look at this video. If you can see on your left, that is the baseline. The baseline, probably somebody has touched the recording electrode, and that's why it doesn't look very good. We probably should have repeated another baseline for this patient. Okay, but let's see how it progresses once we do the ECT. Okay, try to take note of which phase it goes into. Okay, I think for here, recruitment probably ends at around 1 second. It goes to polyspike just for 1 more second. Then it's already in the polyspike slow wave complexes. And if anybody is doing this ECT, I'm sure at this point of time, you feel quite happy already. But then you have to watch out for prolonged seizure instead. Okay. So continue on and off. It looks like it might be a bit disorganized, but actually it still continues. The slow wave complexes still continue. Okay. And so it has reached 37 seconds. You're happy. And then here you see, oh, actually it starts to change. So it's probably gone into a termination phase. Okay. And then termination up till 40 seconds. And then subsequently is the immediate post-ictal phase. Okay. Let us look at another one. Okay. Is this the same one? Oh, sorry. Yep. Okay. So let us look at case 4. Okay. No baseline for this video, but let us look at this. What has happened? Clearly, there is no recruitment. There is no polyspike. If you do a baseline, this is probably comparable to your baseline. So instead of waiting for a very long time for this to continue, maybe by 25-30 seconds, I think you can tell very confidently that there is no seizure that has taken place. So this is power and energy that is not high enough for this patient. It hasn't reached the seizure threshold yet. So what you do is you stop it, allow a 30-second refractory period, and then you give another dose at a higher, you give another ECT at a higher dose. Okay. And then now we move on to the 5th one. Okay, this looks terrible, right? Okay, I'm still going to play it anyway. Okay, so again, like I mentioned earlier, when an ECT is ongoing and you see things that does not make sense, okay, don't panic yet. A lot of snap judgments to be made, a lot of troubleshooting to be made. If you see the EEG1 and EEG2, actually a seizure is actually ongoing. The one where you don't have the tracing is the EMG, the third line. Okay, and these are all strips on for timatron machines. This is how it's displayed. The Magna machines are slightly different. Okay, so actually if you look first line and second line, the EEG is still ongoing, the ECT is still ongoing, the seizure is still ongoing. Don't panic, you actually don't have to stop it right away. You can still interpret. Okay, don't stop the machine yet because you want to make sure that you see how the seizure goes. Okay, these interferences of course makes it harder to interpret, but actually you still can. And for this patient, the ECT is actually it is actually adequate. It is actually an effective seizure. It goes very fast into slow wave complexes, if you can see. And then at around this mark, it becomes disorganized. Okay. And then it terminates at around, I think, 30 plus 40 seconds. Okay. All right, so troubleshooting along the way is very important. Okay, so these are my references. I want to have a special shout out to my house officers that help me trace the folders and help me take the photos and the videos. Okay, to Shazwani and Faiz Iqbal. All right, so however much you study, you cannot know without action. A donkey laden with books is neither an intellectual nor a wise man. So what I'm saying is that after the course today, I hope you have a brief idea. Okay, this is how ECT should look like. But of course, just like how cardiologists interpret ECG, you need to see a lot, you need to do a lot to know it better and better. Then you become more confident in your ECT administration. Okay, that's the end of my second topic. Thank you very much. Any questions?
Sorry, Dr. Chi.
Yep.
I want to ask, in the trace the ECT punya tu tracing tu kan dia ada macam line dekat atas tu, there's a line.
Okay, very good question. Ni Dr. Farah Najihah.
Can you explain a bit about that? Yang tu I tak faham.
All right, let me share screen again. I'm very happy you pointed that out. I actually wanted to highlight that as well. Okay. Let me see, which is the... Okay, so if you look at this EEG strip, okay, I think Dr. Farah Najihah, what she's referring to is this. Is referring to this line, okay? And this line is actually our ECT machine trying to detect, has the seizure taken place, okay? Where does the seizure end? But of course, this is all machine-based algorithm calculation. Betul tak? So just like how ECG can also help us interpret ni ada arrhythmia ke tak, this one sinus rhythm or not, it is the same with our EEG machines as well. But it is still not accurate. For example, if you see in this picture kan, the line ends here, but clearly the ECT has already ended. The seizure has already ended. So based on the machine's knowledge, this is where it thinks that the ECT has ended. Okay, but it's actually not accurate. Yeah. So we don't rely on that anymore. Okay. It is a helpful tool, but we do not interpret based on the line. Okay, I think there are other examples. Let me see. My video ada. Like if you look at this, because the post-ictal suppression isn't very clear, again, the machine doesn't know. The machine only knows classical ECT, how to calculate. But when it deviates from what it expects, then it will end very abruptly here. But actually, this one has ended even earlier. Okay. If we look at our videos, let's see if any of them have this. this feature. Okay. So if you look at this, no ECT induced seizure, right? But then the line will still appear. Okay, then only it disappears. Then only it recognizes, oh, actually there is no ECT seizure happening. Okay. If you look at case 3, the line doesn't even appear. Yeah, so the machine doesn't know how to interpret this one, even though this is a good seizure. So nowadays, we have to base it on our own knowledge and our own interpretation rather than actually looking at the line on the machine, on the EEG strip. Okay, thank you for your question. Dr. Farhan Najihah, does that answer your question?
Thank you, Doctor. Thank you.
All right, thank you. Okay, any other questions? I see Dr. Khalil. Dr. Khalil can answer questions. Okay, if you don't have questions now, but you have questions later we still have post-test and Q&A session, so we can discuss more later. Okay. All right. Thank you very much. Thank you everyone for joining our course today. Oh, wait, there is a question now. Okay, let's answer this question first. Is it okay if I allow up to 230-second post-ictal? Sorry, Dr. Rahman, I don't understand your question. Okay, I wonder whether this answers your question. When you are in doubt about how your ECT is progressing, up to 20 seconds. Sure, you can. If you are in doubt as to whether your seizure has ended, it is better to let it run. Okay, let your EEG continue reading. Okay, sometimes maybe NS wants to get the patient out, they will interfere a bit. But if you have any concerns, you tell your NS tactist that you're not very sure whether the ECT has properly ended yet. You still need to continue the EEG monitoring. Okay, until you're confident, then only you stop. So it doesn't really matter how long you continue your post-ictal for. Okay, where you want to identify is where the termination ends. Okay, and that will determine whether the seizure is okay or is it prolonged. Okay, does that answer your question? Okay, assume that it's answered. Okay, thank you very much. Thank you for your question and thank you for joining the course. Okay, I pass back to our MC, Dr. Anis.
Terima kasih kepada Dr. Chi atas ceramah yang telah saya sampaikan sebentar tadi. Jadinya untuk kesimpulan ceramah daripada Dr. Chi, kita kena tahu yang penting pertama sekali kedudukan elektrod tu kita kena pilih jenis ECT yang mana kita nak guna. Kedudukan elektrod, connection elektrod tu dalam keadaan yang betul untuk mengelakkan artifak, dan bila kita dah buat ECT tu kena pandai interpret dia punya result tu. Bukannya kita just tengok nampak cantik kita terima as effective ECT. Jadi kita kena belajar untuk interpret ECT tu sebab kita kena buat decision untuk next ECT sama ada nak continue the same power ke ataupun kita nak kena increase dia punya power ke macam mana. Okay, jadi sebelum kita teruskan dengan ceramah kita yang terakhir pada hari ini, saya ingin meminta kepada semua peserta untuk buka kamera. Kita nak ada sesi bergambar sikit untuk kenang-kenangan. Okay, jadi bolehlah semua peserta bengkel yang join secara virtual untuk on camera. Penceramah juga sila on camera untuk kita bergambar. Untuk peserta fizikal, sekejap ya. Mana ke sini? Dah ambil tak tadi? Okey, yang ni untuk peserta virtual kita buat. Screenshot. Okay, semua dah ready, cantik-cantik, bagi tudung, bagi lagi rambut. Okey, boleh. Kita buat dalam kiraan 3 ya. Okay. 1. Sekejap. Okey, okey. Boleh, boleh. Okay, alright. 1, 2, 3. Okay, lagi sekali. Ni ramai lagi yang tak on kamera ni. Alright. Okay, dah selesai sesi bergambar kita. Okay. Jadi untuk yang fizikal dah selfie semua dah settle Okay. Alamak, komputer tak ada kamera, alamak. Aduh. Okay, so kita teruskan dengan ceramah terakhir kita yang bertajuk ECT Stimulus Dose Strategies yang akan disampaikan oleh Dr. Muhammad Dabahan Khalil bin Azizan. Sedikit pengenalan berkenaan dengan Dr. Khalil ya. Beliau merupakan graduate Master of Medicine Psychiatry daripada University Science Malaysia dan kini beliau merupakan pakar neuropsychiatry di Hospital Sultanah Nur Zahirah Kuala Terengganu. Beliau mempunyai minat di dalam acquired brain injury, epilepsy dan functional neurological disorder. Terima kasih doktor di atas kesudian untuk berkongsi pada hari ini. Dengan segala hormatnya, saya ingin menjemput Dr. Khalil untuk menyampaikan ceramah beliau. Dipersilakan doktor.
Boleh dengar suara saya?
Boleh doktor, boleh.
Boleh, okey, alhamdulillah. Sharing ke mana ni ya? Oh ni. Sorry. Slide boleh nampak?
Boleh doktor.
Okay, alhamdulillah. Assalamualaikum and good morning. My name is Khalil. I am from Asia Sunset Neuropsychiatry. Thank you for HDAA for inviting me for this course. So Dr. Chi Jun Heng gave me this topic, ECT stimulus dose strategies. All right, so basically TLDR, too long don't read, initiate stimulus. So what we need to do for ECT is firstly we initiate stimulus. If there is no seizure, we keep increasing until there is adequate seizure. And then if let's say the seizure occurs and then it's inadequate, so we increase the stimulus further until EEG seizure is adequate. So we need to, in order to do this, we need to know what are the clinical the EEG features of the markers of seizure adequacy, and then we need to know also how do we dose our stimulus, how to increase or adjust the stimulus. So in order, so this topic is also quite related to Dr. Chi's topic just now. Okay. All right. So I think Dr. Chi already mentioned about this. So there are a few types of waves that we can see in EEG. For ECT, for example, the first one that we need to know is polyspikes, in which spike means, okay, we can see here it's sharp waves. It's quite sharp. Okay, spike is sharper than sharp, lagi tajam, yeah. And then if there's only one, it's called spike. If there's a lot, it's called polyspikes. Polyspike is related to tonic seizure. Yeah, and then another features that is important is spike and wave. We can see that there is spike and then there is a slow wave. Slow wave means wide. The waves are wide, in which by definition slow wave means there are 10 waves, less than 10 waves in 1 second. Yeah. So sometimes the spike is not really seen or mildly seen. But then the most obvious one is the slow waves. Okay, so these are the phases of the EEG. Dr. Chi, I believe, already mentioned about this. There are 5 phases or 4. Firstly, recruitment phase, tonic phase, which is polyspike, clonic phase, which is polyspike and slow waves, termination phase, and also post-ictal suppression. So in order for us to ideally, we need to have baseline recording. Yeah. So before we stimulate, we press the button so that it captures the brain waves before the stimulus. Usually we take only one baseline recording, but I recommend for you to take 2 baseline recordings. Yeah. Firstly, before giving anesthesia, and the second one is after given anesthesia. This is because the waves would be different. Yeah. After post anesthesia, it's a bit chaotic. Yeah. So this is important for us to determine whether seizure already stopped or not. Sometimes it's from the last discussion, there is a discussion on continuing EEG strip because we are not really sure about whether the seizure has stopped or not. These 2 baselines can help us to determine whether the seizure already stopped or not. Because if let's say after the seizure, let's say if we see that after given stimulus, the seizure, we are not really sure whether the seizure has stopped or not, we can go back to the baseline recording. If the baseline recording is the same as post-anesthesia, which is a bit chaotic, so it means already stopped. If we only have 1 recording, sometimes we are not sure whether the baseline, the EEG that looks like already stopped seizure is similar to the pre-anesthetic because the anesthesia already wear off or not, or it's the anesthesia is still in the system. So it can help us to determine whether the seizure already stopped or not. Okay, firstly, the first phase of post-stimulus EEG is recruitment phase. Recruitment phase is considered recruitment is the process of the progressive enlargement of the amplitude. Yeah. So usually, if let's say we could say sort of like the recruitment phase already finished and go to other phase when the amplitude is already stable. Kalau masih lagi membesar, makin membesar, mungkin masih lagi in recruitment phase. And then polyspike, in which very sharp. So this is tonic phase. And then clonic phase is when there is mainly a polyspike as slow wave or, okay, for example, focus here. Yeah, okay, focus here. Let's say a lot of time our EEG would look like this. and continuously. Yeah. So we can see here, kecil kat sini. This is spike. Sometimes the spike is inside the slow waves. Yeah. Ini satu lagi, spike and then slow wave. All right. So and then termination phase. Termination phase is when there is reduction in the amplitude and regularity of the complexes. We'll give example later. All right. And then after that, the post-ictal suppression phase or post-ictal phase. So post-ictal suppression is when there is flattening of the EEG. Sometimes it's more flat. It's flatter than the baseline. Okay, all right. So we already know that what are the features of EEG in ECT, and then now we need to know the EEG features that points towards the seizure is already a good seizure or not, which is whether the seizure is adequate or not. Okay, why do we need to determine whether the seizure is adequate or not? The main reason is adequate seizure correlate with clinical response, usually, yeah, but not necessarily. Sometimes the seizure looks inadequate, but the clinical response is good already, especially in the elderly, yeah. All right, so firstly, if for us to say that the recruitment phase is adequate or not, usually the recruitment phase needs to be less than 5 seconds, more or less, yeah. From here, this I know that Hospital Kuantan uses Tamatron, but the strip is from Mecta 500, 5000 M, I think, yeah. Here we can see that there is gradual increment of the amplitude, and then after this, the amplitude more or less stable. So we can see until 5 seconds. It's still in recruitment phase. After that, only it goes to the polyspike. Yeah, the polyspike. So this is already tonic phase, and then we can see there is we would say the wave already mengangkang lah, lebih kurang. So this is slow waves already. Yeah. Okay, so second is adequate bilateral amplitude more than 10 seconds. Our CPG define adequate amplitude as 3 boxes or 15 millimeter or 3 large boxes. But then, but then we need to know also what is our setting, because we can enlarge the waves or reduce the waves, yeah, the wave size based on setting. So the usual setting is 0.02 millivolt per millimeter. So jadi kalau 0.02, so it will be around 0.3 millivolts. Mana? 1, 2, 3, 4. So this one is for 4 boxes. So this is adequate already, more than 3. Okay, and then symmetry. So ideally, we want the left and right brain to have similar morphology of the seizure. For example, this strip, you can see that it's almost identical. Yeah, so this is good symmetry. So our CPG said that we need to have at least 50% of the total duration of seizure to have symmetry. And then the fourth one is bilateral EEG seizure more than 15 seconds. So we consider this from, we need to calculate or to see this from the duration from the recruitment until the end of seizure. Next is, we need to know that we need to have abrupt termination of endpoint. Di mana seizure sawan, and then terus stop kalau boleh. Yeah. Okay. There are 2 ways to determine. Firstly, based on the value that's given from the ECT machine, from Tamatron, and then the second is from eyeballing. Okay. From here, we can see from the eyeballing, we need to look at termination phase as well. Like I mentioned before, termination phase means there is gradual progression and the waves are becoming more less regular, more irregular. Okay, so we can see that, so more or less stable here. Boleh nampak pointer tak? Boleh kot?
Ada doktor, nampak?
Ada, okay, alright. Okay, so pointer saya menunjukkan ini more or less stable, the amplitude, kemudian start daripada 14 second dah makin turun, ya, dah makin turun dan makin irregular, ya. So this is from 14 second to 70 second is termination phase, and then the EEG flattens. So jadi 1, 2, 3, 4, 4 seconds, which is good, ya. And then abrupt EEG flattening, which is good. And then the second one is from the post-ictal suppression index, PSI, from the report of Tamatron strip. Okay, you can see here post-ictal suppression index, and my arrow shows that it's 99.7%. So for saya tak tulis kat sini. So for Tamatron, it's considered good PSI when the PSI index is 80% or more. However, this calculation by computer can be affected by artifacts. Dr. Chi already mentioned about artifacts before. And one of the artifacts include when the electrodes become loose, or during bagging, yeah. So bagging pun kita akan nampak macam waves juga, yeah. So the computer might consider it, put into the calculation that this wave from the bagging is part of the EEG, yeah. So it might calculate. So this is okay if the number is more than 80%, which is good, so we can accept it. If the number is less than 80%, we need to look. We need to eyeball the strips, yeah. Okay, for MACTA machine, there is the adequacy parameters in which are more or less the same as well. It's different, but then it's computerized as well. Still, also affected by artifacts as well. So adequacy definition from the MACTA machine is considered adequate if the adequacy scoring is more than 50%. So my advice is kind of the same as well. If you use MACTA machine and the adequacy is more than 50%, so we take it that it's good. If less than 50%, we need to look at the whole strip. We need to judge ourselves because we are not sure. If we don't look at the strip, we are not sure whether there is artifact or not. Okay, from the our ECT CPG, it is said that neuron ECT EEG algorithm rating scale or NEARS is a step-by-step approach for ECT, EEG or EEG visual pattern recognition on seizure adequacy from two-channel EEG recording after administration of stimulus dose during the ECT procedure. So what the team did was they produced this recruitment phase, amplitude phase, duration. They give this index. Recruitment less than 5%, amplitude three boxes in more than 10% of the slow wave complex, symmetry more than 50%, symmetry from the recruitment to slow wave phase, duration more than 15%, and also adequacy, which is post-ictal suppression index more than 80% or adequacy 50%. Yeah. Okay. So they mentioned further mention inside our CPG that this sequential visual analysis of the EEG is based on 5 indices as follows: recruitment, amplitude, symmetry, duration, and also degree of post-ictal suppression. According to our EEG, this degree of post-ictal suppression is shown from the PSI in the Tamatron, and also adequacy more than 50% in MECTA. All right. However, there is a problem with this, the last, the fifth number, which is degree of post-ictal suppression. From the MECTA spectrum, it says that maximum spectrum manual, if we read the manual, it says that they have a lot of research. From the research, they produce the algorithm to say whether the EEG pattern is adequate or not, based on the EEG features and also the clinical features in their in the researches. Yeah. Okay. They quote this the names Noblela, Crystalla, Sapers, Focus, and Herdelica. So I review back almost the individual. Diorang tak tulis apa finding dia, but then I reviewed back the individual research. For example, Nobler said that they include post-ictal suppression, and then Foucault said include recruitment phase, symmetry, and strength of the seizure. Strength tu maksudnya tadi amplitude lah, lebih kurang ya, more or less. So basically, the adequacy of 50% in MECTA already include the other NIAS criteria, all the NIAS criteria. Yeah. Jadi sebenarnya adequacy ni sebenarnya tak perlu untuk kita cakap nak masuk dalam NIAS ni. Ya. Jadi because of this, my suggestion, if you want to use NIAS, firstly for Timatron, we just follow NIAS as it is if the PSI is more than 80%. But then if the PSI is less than 80%, we need to see the graph and we decide for ourselves, yeah, whether the last one, which is the last parameters, which is adequacy or PSI, is actually good or not. Yeah. For MECTA spectrum, because the parameters in adequacy already include all the NIAS parameters. So if the adequacy is more than 50%, I will sit up and tengok benda lain dah, and just accept that it's good seizure based on your clinical judgment, in which clinical judgment include the patient is whether the patient improve or not. Yeah. If the adequacy is less than 50%, we need, and then we are not sure whether the calculation is actually correct or not, because there it might be incorrect because of there are artifacts. So we can use NIAS. Yeah. Okay. This is my suggestion lah. Okay. And then the next topic is stimulus dosing strategies. There are two ways, CPG, cara CPG, and then there are the practice that's used in a lot of centers and also in literature, in which they use seizure threshold times 1.5 in bilateral or 5 to 6 in unilateral. We go first to the one that's mentioned from CPG. Okay, before that, how to choose the initial stimulus dose. Yang maksudnya stimulus yang pertama untuk pasien tak pernah ECT atau this current ECT course, it depends on the machine. For Timatron, for male we use 10, for female we use 5%. For spectrum MECTA, we use 4% for male and female 2%. This is because the difference in seizure threshold in among the genders. So this graph is from CPG on how we start and then we adjust the dose. All right, so more or less the same graph here. Firstly, we start the stimulus based on the one that we mentioned before. Hospital Kuantan use Timatron, so Timatron we use, let's say the patient is male, so we use 10. Yeah, initial stroke kita bagi 10%, and then we see whether there is seizure or not. Yeah, if there is no seizure, according to the CPG, for the tamatron machine, we tambah 5%. So we no seizure, so we increase stimulus to 15. 10 tambah 5. And then no seizure lagi, kita tambah 5 lagi. Jadi 15 jadi 20. Yeah. If this we are using the SMACTA, it's a bit different. After we start at 4% for male, and then tak ada seizure, so we kali 2. Jadi 8 kali 2 lagi. Tak jadi lagi kali 2 jadi 16. Yeah. So it's a bit different. Okay, let's say after given stimulus, let's say 10, tamatron 10, 15 lah, 15 ataupun 20 lah, kita say 20 senang nak kira. 20 seizure elicited. And then bila ada seizure, kita tengok nearest adequate seizure, dah kita boleh dah berhenti. So tak payah, lepas tu repeat next time the same dose. Ya, katakanlah seizure tu kita tengok nearest tak cantik, and then kita kena kali 20 ni kali 1.5. So jadi 30. Repeat jadi 30, and then kalau adequate seizure stop there. Kalau tak jadi juga kita boleh naik 30 kena kali another 1.5, which is 45. Naik lagi macam tu. Alright. So that's one way, yeah. I'm not sure whether Dr. Chia mentioned about unilateral or not. So I would also like to mention on unilateral. So dosing strategy based on seizure threshold. In which before that we need to know the definition. Seizure threshold is the dose that can produce seizure. Yeah, different authors different regarding the duration. Setengah kata any duration kalau 1 saat pun sawan, so that's considered already achieved seizure threshold. Some books say that 15, some books say 25%. So up to you. I would say any duration lah, senang nak fikir, tak payah fikir susah-susah. And then supra-threshold stimulus. Supra-threshold stimulus means once we achieve seizure threshold, we give another stimulus that higher than the seizure threshold. Usually we give 1.5 to 2 times higher for bilateral. Untuk unilateral, we need to increase 5 to 6 times unilateral times from the supra-threshold stimulus. We go back to our flow chart just now. Okay, let's say we give stimulus, let's say 10% untuk lelaki, ya. Kemudian kita bagi 10% tak ada seizure, and then for tamatron we increase another 5, jadi 15. So increase stimulus, ada sawan. Okay, ada sawan, and then tak kisahlah sawan dia tu cantik ke tak cantik dalam EEG, near to perfect or not perfect. Kalau kita guna teknik untuk seizure threshold, maksudnya bila first seizure tu that is seizure threshold, and the seizure is called threshold seizure. So kita tak cukup lagi threshold seizure, kita nak lagi tinggi. So katakanlah 15 dapat sawan, tak nak kita kena naik jadi another 1.5. 15 plus times 1.5 would be 22.5. So 22.5 you can up to you. You can give like kalau tak boleh naik jadi 2 ataupun 1 boleh naik, kena naik 5. So you can give whether 25% or 20%. Alright. So this is dosing strategy of the seizure threshold. So dosing strategy based on seizure threshold. So if you want to use the unilateral, you cannot use the CPG way. You need to have the supra-threshold stimulus. So you need to determine seizure threshold, and after that kena kali 6. So katakanlah 10% ataupun 15% sawan, dapat sawan, and then kena kali 6. So 15 kali 6 berapa? 90. Yep. Terus bagi 90 on the next session, next simulation. Okay, this is same like I mentioned before. Okay, so yep, I mentioned already that we need once we get the seizure threshold untuk unilateral ECT, and then we kali 6. If let's say later kena naik lagi, kita tak perlu kali 6 dah, kita kena naik 1.5 from the last dose. Okay, so less common electrode placement include bifrontal and also unilateral. Yeah, sebenarnya the unilateral should not be less common usually, supposedly, because kalau boleh kita kena belajar lah buat unilateral, especially untuk patient MDD ya. Walaupun dia lambat sedikit, but then cognitive side effect is less. Yeah. Okay, firstly we go to tadi I joined this morning about half an hour macam tu during Dr. Tan punya talk. Yeah, so Dr. Tan mentioned about the patients with heart disease, post-MI, something like that. Okay, so yes, of course, it's relatively contraindicated for us to give to prescribe ECT for patients with arrhythmia or heart disease. However, sometimes we still need to give with usually NS will ask for high risk consent lah. Yep. Okay. So we can see here from the picture gambar otak ni, this green area is the insular cortex, yeah. And this one, garis ni yang putih ni, this is insular cortex. Okay. If we give the stimulus at the function of insular cortex include for the autonomic function, the control of the blood pressure, control the heart rate, control sometimes the abnormality on the insula can also cause arrhythmia. Yeah. So let's say we give bilateral ECT in which we give electrode at the temporal lobe. Yeah. So bila kita bagi kat temporal lobe, belakang temporal lobe ya adalah insula. So dia boleh kacau heart rate, kacau BP, ya. But then if we give the stimulus bifrontal kat depan, kat sini ya, dekat sini, jauh sikit daripada insula, still could affect, but less affecting the insular cortex, so less affecting the blood pressure, less causing arrhythmia, yeah, less causing the heart tachycardia. So we need to consider, we can consider this bifrontal for patients with heart disease, yeah. Sometimes patient yang senang dapat post-ictal delirium, kita boleh juga nak buat bifrontal, yeah. So how to place the electrode bifrontally is 5 cm above the outer quantus of the eyes. Kalau kita ada yang jenis electrode yang jenis stiker, that's better. Lagi senang kita nak tampal stiker. But depan ni nanti nak tampal EEG electrode juga. So macam banyaklah benda nak tampal kat sini. So jadi serabut sikit. Kalau kita guna stiker senang sedikit, ya. Alright. So this is right unilateral electrode placement. The placement is temporal, the same area as bilateral on the right side. And then another one is vertex electrode, tengah-tengah, and then tepi sedikit, 1 or 2 cm laterally. Ya, jadi dua-dua electrode ni adalah dekat belah kiri, belah kanan kepala patient. The reason we do right unilateral is more because of most of the patient, the dominant brain is the left side. So all this memory center is mainly on the left side. So if we give at the right side, less damage to all, well, not less damage, sebab ECT takkan cause damage, less affecting the cognitive cognition, walaupun sebenarnya dua-dua belah temporal lobe adalah untuk cognition juga. On the left side is more of verbal memory, right side there is more of non-verbal memory. But then if the right side is being disturbed by EEG, so patient would have more symptomatic. So when do we need to increase stimulus? Firstly, because when NIAS is not good, second, even if NIAS is good, tapi EEG dia nampak makin teruk, walaupun kalau nak kira kriteria macam boleh tahan lagi kalau kriteria NIAS ni, especially if there is no clinical improvement on the patient. Second is missed seizure, in which lama-lama bila katakanlah kita stimulate dah kali ke-5, kali ke-6 the same dose, seizure tak datang, missed seizure. So kita kena naik lagi the stimulus. Okay, what to do if there is inadequate or missed seizure? Firstly, we go to definition. What is inadequate seizure? There is no exact definition. Definition, it could be 15 seconds, 20 to 25 seconds. However, sometimes short seizure is still inadequate, in which the patient still should respond. However, barely suppressed short seizure can have adequate duration, but inadequate efficacy. Jadi apa-apa pun clinical judgment. One of the, kalau kita ikut CPG, so inadequate seizures means CPG near score of 1 or 2, or 3 if lacking clinical improvement. So this is when we increase the seizure stimulus. What is missed seizure? Missed seizure is maksudnya tak ada sawan lah. It defined as the absence of any motor clonic movement or EEG seizure activity after a stimulus has been administered. Okay. Tak tahu ada orang dah mention sebelum ni ke tidak. MO saya pun macam ada selalu silap. Kadang-kadang dia tengok EEG okey, tapi patient clinically tak sawan, tahu? Tak ada clonic movement. Jadi my suggestion, jangan peduli pasal patient tu ada clonic movement or not. Because what we need to see is whether the EEG has seizure or not. Kita fokus kepada EEG. Kalau dua-dua bolehlah kita catat. Kalau satu saja EEG tak ada sawan, tapi kita tak nampak physically ada sawan, so let it be. Kita just accept EEG. Because if we give adequate muscle relaxant ataupun terlebih muscle relaxant untuk the body weight ke ataupun patient physiological functioning, jadi kadang-kadang tak nampak sawan sebab patient dah paralyzed. Tapi EEG still running, ada sawan. Okay, so go back to artifacts. So we need to review the EEG and then whether we see, kita tengok betul-betul sama ada sebenarnya kita nampak ni sawan ke ataupun sebenarnya artifact. So kita kena judge based on that. The second sentence, because of the onset of seizure activity may be delayed, particularly when the stimulus is barely seizure threshold or at seizure threshold, we need to wait 10 to 15 seconds following the stimulus before concluding that the seizure does not occur. Sebabnya kadang-kadang sawan ni lambat sedikit. Kadang-kadang ambil masa 5 saat selepas tu ataupun 10 saat. Jarang-jarang lah. But then still could happen. So kena berhenti sekejap sebelum 15 saat sebelum kita bagi another stimulus. Alright. The cause of inadequate of missed seizure include tak cukup stimulus, makin lama seizure threshold makin naik sebab kita dah bagi banyak ECT, impedance terlalu tinggi, poor electrode contact with skin. Kadang-kadang bila kita tekan tu, kita tekan tak habis, premature stimulus termination, dehydration, hypercapnia, anticonvulsant drugs, benzodiazepine. Kadang-kadang kita tengok sebab kadang-kadang orang yang buat ECT dengan orang dalam ward lain. Jadi dia tak pass over betul-betul, kita pun tak tengok betul-betul file. Rupa-rupanya malam tu patient macam buat kacau, malam tu dia bagi benzo. Jadi banyak sikit. Jadi siangnya tak jadi sawan. So kita kena tengok sikit chartnya. Excessive anesthetic induction agent. We know that kalau kita tengok Sarawak protokol dulu-dulu, tak tahu sekarang macam mana Sarawak protokol untuk patient status epilepticus. Lalu sekali kalau tak jadi semua-semua tu midazolam semua-semua tak jadi, lalu sekali dia orang akan bagi propofol. Propofol is also anti-epileptic. Ya, kadang-kadang kita bagi terlebih propofol, patient tak sawan juga. Ya. Dan untuk patient yang prolonged seizure, antara treatment dia kita bagi propofol lagi untuk prolonged seizure untuk ECT lah. Kadang-kadang kita boleh bagi apa-apalah kita ada. Kadang-kadang kalau kita ada benzo, kita boleh bagi benzo, ataupun kalau NS tu terlebih banyak lagi dia punya propofol, kita boleh add another propofol. Ya, so sebenarnya propofol tu sendiri adalah anti-epileptic. Sometimes kalau kita bagi stimulus terlalu tinggi, dia boleh dapat sawan boleh jadi pendek ataupun tak ada sawan juga. Sometimes, ya. Okay. Like I mentioned before, some patients, especially elderly, can have short seizures or nears tak cantik, but then the patient responds well. So what is the most important is the response of the patient rather than the cosmetic of EEG. Yeah. Okay, what to do in cases of inadequate or missed seizures? Okay, firstly kita kena bila kita patient ni macam tak cukup sawan ataupun tak sawan, and then we need to check what's the problem. Tengok output, kita tengok balik dia punya record. Macam mana kalau biasanya kalau report dia akan cantik kalau semua parameter akan ada kalau betul lah. Ya, kalau kontak cantik. Kalau tengok parameter dia macam kita nampak NA lah, not applicable lah, banyak benda-benda kita nampak macam tak macam seolah-olah macam dia tak boleh nak record. Kita kena check balik kita punya wire semua tu, ya. Kalau mesin rosak, if a malfunction of ECT machine is suspected, tak bolehlah kita nak bagi another stimulus, takut kesian patient. If the inadequate seizure or missed seizure is not caused by the technical factor, maksudnya kita kena stimulate at the higher dose, ya. Dan kena juga, saya cerita tadi, kena juga tengok obat sama ada obat baru ataupun dia berhenti ubat menyebabkan interaction, ya. Consider also asking our anesthetist to do hyperventilation. Hyperventilation is defined as giving ambu bagging for 25 breaths more or less per minute for 1 or 2 minutes lah. Itu boleh membantu merendahkan seizure threshold, so hopefully the patient can get seizure with the stimulation. Like we mentioned before, antara penyebab missed seizure adalah hypercapnia, terlalu banyak CO2 dalam badan dia. Dan kalau kita kurangkan CO2 jadi terlebih rendah pun, agak rendah daripada yang normal pun boleh membantu untuk mengurangkan seizure threshold. Alright. In general, inadequate seizure is if let's say inadequate seizure, maknanya sawan tapi tak cukup, dia lain sikit waktu untuk kita tunggu untuk restimulation. Sebab bila lepas sawan, patient tu jadi macam kita stimulate, mungkin tak akan jadi sawan dah. Ya, sebab refractory period, brain tu masih nak adjust dengan yang sawan yang tadi. Jadi kita kena tunggu lama sedikit, 30 hingga 60 saat. Biasanya kita pun dah restless dah, bimbang juga sama ada patient akan bangun ke tidak. Tapi kita buat sibuk lah, buat sibuk chat ni, lepas 30 saat, kita belah, dah kalau kita takut ayah dah semarah kan. Buat sibuk lah, chat ni, kenapa jadi chat ni, berlakon sikit. Dan kita bagi stimulus lebih kurang lepas 30 second lah, at least 20 second lah kita tunggu. If suspicion of missed or short seizure because the stimulus is too high, so consider to retitrate ECT dose lah. Untuk retitration, kalau kita rasa macam obat dia dah banyak berubah, masa kita katakanlah ECT sekarang dah berapa, 5 session, 6 session, kita nak continue sampai 12 session for example. Dalam masa 2 minggu tu daripada start ECT sehingga nak jadi 5 atau 6 tu kita dah banyak ubah obatnya. Jadi kalau macam tu mungkin kita kena retitrate daripada kosong baliklah, daripada 10 untuk lelaki dan 5 untuk perempuan tamatron, ataupun 4 dan 2 untuk Mecta, ya. Ataupun kalau kita tengok tak berapa banyak dos obat, kita tak ada banyak sangat dos obat yang kita adjust, kita boleh balik kepada seizure, the seizure threshold. The first seizure that the patient got during this ECT session, ECT course, at what dose? Kalau katakanlah 25 dos, kita boleh start 25, kemudian kita adjust accordingly, kita naik lagi kalau tak cukup lagi. Ya, kena tengok sikit lah. Alright. Okey lah, saya rasa itu saja apa yang saya nak cerita. So, we give to case examples. Kita macam sekejap. Oh, sekejap je baru. Okay. So, case example. Firstly, kes mana ni? HKL saya rasa kes ni. 19 years old man, diagnosis is schizophrenic disorder. ECT was commenced after 1 week admission. HKL used Mecta. Then the reason of ECT is disturbing in the ward, aggression, not responding to medication, and then we need rapid definitive response because the patient was very aggressive. Okay. So first ECT, because this is Mecta, they use 4% stimulation. Kalau untuk tamatron kita bagi 10%. So dia bagi stimulation 4 saat tak nampak sawan. Jadi dia pun berhenti. So kalau kita tengok kat sini memang kosong lah, tak memang sangat tak cantik. Tetapi sebenarnya so this is missed seizure lah, which is no seizure. So actually we need to continue at least 10 seconds so that we can rule out that this is delayed seizure. So if the seizure stimulation, if there's no seizure and there's no delayed seizure, kita naik 2 kali ganda. Because this is Mecta, jadi 4 kali 2 8. Kalau untuk this we are using the tamatron, so daripada 10 kita start jadi 15. Tambah 5 lagi. Kemudian next, the first session juga, tapi second stimulation. Dia bagi 8%. So 8% kita tengok ECG dia macam ni. Lepas tu, what is the next action? Kita tengok. Okay. So kita tengok recruitment phase. Lebih kurang naik, membesar, kemudian stable. Stable lebih kurang 3 second or 4 second. So recruitment phase is according to this adequacy. Okay, kita pergi adequacy dulu, sorry Untuk sebab ini Mecta kita tengok adequacy. Kita tengok adequacy kosong. Okay. So, kosong kita pun macam jangan percaya sangat sebab kita takut ada ini disebabkan oleh apa ni, disebabkan oleh artifact. Kalau kita tengok ni, nampak macam sawan dah berhenti tapi masih lagi naik turun. Mungkin apa dia ni? Bagging ke apa ni? Jadi kemungkinan makta dia termasuk dikira sekali this artifact dalam pengiraan dia. Ya. Okey. So kita tengok recruitment 4%, 4 second. Adequate amplitude lebih kurang berapa saat je? 1, 2, 3. 3 saat. 3. Sini 3 saat tambah nanti 3 saat. 6 saat. 5 saat dan 6 saat. Ya. Okey. So kalau nears nak 10 second. Ya. Symmetry more than 50%. Symmetry start bila ni? Simetri sini tak berapa simetri. Mungkin clinical judgment lah. Cukup ke tak cukup? Mungkin saya cakap more than 50% no. Tapi kalau tengok-tengok balik macam mungkin cukup. Jadi tak kisahlah no. Tapi kalau kita cakap no. Duration of EEG more than 15 second? Yes. Sebab dia 16 second. Abrupt termination, kita tengok laju. Kemudian dah start turun. Daripada start turun ni sehingga flat lebih kurang 1 or 2 second. So abrupt termination, yes. Ya. Jadi kira-kira berapa? Yang positif ni 3. Kalau 3 equivocal lah kan. Okay. Equivocal. Tapi terasa macam jalan nak naik lagi equivocal saja. Bila kita equivocal is based on our judgment. Kita rasa kita nak naik ataupun kita nak turun ataupun kita nak tengok respon dalam buat macam mana. Jadi kita boleh sama ada nak stimulate ke tidak. So this doktor dia naik stimulation kepada jadi 8 kali 1.5 adalah 12 ya. Jadi dia naik, adequacy masih lagi kosong. So nears. Okay. Tengok second ACT. 8, confuse saya. Adequacy 12%, adequacy kosong. Alright. Okay. So kita tengok adequacy kosong. Jadi kita pun terus kepada nears ya. Kita tengok recruitment phase berapa ni? Lebih kurang 6, tak berapa cantik ya. Lebih kurang 6, 7. Jadi tak berapa cantik. 7 seconds. Amplitude 3 boxes more than 10 second. Kita tengok bolehlah. Adequate. Lebih kurang 2 atau 3, lebih kurang. So lebih kurang 12 saat. Okeylah. Symmetry more than 50%. Yes. Ya. Yes ke no ni? Yes. Ya. Duration of total EEG seizure more than 50 second. Yes, 19%. Abrupt termination, yes. Kalau MO ni ditengok, kalau kita kata lebih kurang equivocal to adequate lah. So MO ini kata no need re-stimulation, can continue same dose next time or increase 1.5 based on your the response on the ward. Kemudian ini baru first ECT. Second ECT dibagi berapa ni ya? 18% continue 18% tadi 12. Kita tambah lagi 18%. So bila tambah 18%, kita tengok adequacy adalah 45%. Ya, 45%. Ternampak sini pun macam ada, tak tahu lah, mungkin ECG punya artifact ni mungkin ada sikit-sikit. Ke? Bukan. Okey, alright, tak apa. Kita tengok, so adequacy 45%, jadi kita kena tengok adequacy, kena tengok nears lah. Okey. So adequate amplitude besar, very good. Kemudian however kita tengok sebab dia tak ada adequacy punya parameter kan, so kita kena tengok sendiri sama ada termination is long termination phase or very short termination. So kita tengok dia start jadi irregular start kat sini. Berapa? 23 saat. 23 saat dia irregular slow, makin lama makin kecil. Jadi kita macam dah susah dah kita nak tahu yang mana satu start mana yang betul-betul berhenti. So kita tak tahu adakah lebih kurang dekat sini yang berhenti ataupun dekat sini-sini. Mungkin ini artifact ataupun masih lagi sawan tapi flatten betul-betul dekat sini ya. Alright. So jadi Kita tengok bila kira-kiranya duration of recruitment phase per second, kita tengok tak ada recruitment langsung. Terus daripada stimulate terus jadi besar, ya, tak ada recruitment, which is good, ya, 0. Amplitude 3 boxes more than 10%, the more than 10 second, yes, ya. Symmetry more than 50%, tak, sebab long termination phase ni, ya. Okay, duration of 30 EEG seizure more than 50%, yes. Berapa kat sini ya? Lupa dah, tak perasan. 36, saya punya ni tertutup dengan partisipan punya gambar, ya. So jadi berapa tu? Hampir 40%. Okay. Next section. So equivocal to good lah. Ha? So next section, no need to re-stimulate, continue the same dose or increase 1.5 next time. Okay. Third ECT, dia naik, dia naik jadi 27%. Okay. So third ECT macam ni, adequacy 18%, ya, tak cukup. Okay. Kita tengok recruitment is quite short, adequate amplitude tak berapa sangat, adequate amplitude lebih kurang kat sini. Kemudian kita tengok MO kat sini dia dah stop lebih kurang kat, dia continue je, dia continue lepas tu dia stop kat sini. Tapi kita tengok ada lagi naik turun. Kita tak tahu sama ada ini EEG-nya seizure masih lagi sudah berhenti ke ataupun tak berhenti. Jadi as suggested by Dr. Chi just now, kita sambung je lagi, ya. Kita tahu apa ni, artifact ke, patient berkelip-kelip ke, ya, ataupun sebenarnya masih lagi sawan ke ataupun dah berhenti, ya. Jadi kita tengok. Jadi antara untuk cara kita tak nak tentukan adalah kita sambung lagi kita punya observation, ECG strip, dan kita kena tengok patient juga. Kita tengok ada lagi tak jerky movement ke, kita tengok mata dia kelip-kelip ke. Jadi kita tengok ada korespon tak dengan all these peaks, ya. Okey, jadi kita tengok patient juga pun tak semestinya kita tengok EEG sahaja. Alright. So kalau kita tengok sini, tengok inadequate. Jadi kita kena nak tambah 1.5. Okey, bagi stimulation, next stimulation tambah lagi 40% during the same ECT session, ya, third ECT. Tambah lagi 40%, nampak dibagi adequacy 81%. Ya, so adequacy yang dihasilkan oleh mesin adalah 81%. Kalau kita nak terus accept pun tak apa. Tengok sikit-sikit nampak tak ada problem dengan EEG machine, kita nak accept dengan EEG strip, nak accept pun tak apa, ataupun kita nak pergi ke NIAS. Jadi kita pergi ke NIAS, amplitude, recruitment phase berapa saatnya, lebih kurang 5-6 saat macam tu. Okey, boleh borderline kan, jadi kita nak accept pun boleh, kita tak nak accept pun boleh. Adequate amplitude nampak kuat last juga. Termination phase agak lama sikit, daripada 35 hingga lebih kurang 41 ataupun 44, nampak ada movement artifact sikit. So jadi kalau kita tengok kat sini lebih kurang equivocal to adequate, ya. Jadi kita boleh nak naik ataupun sambung. Dan paling penting kita tengok patient tu improve atau tidak. Yep. Okey. Boleh faham, ya, lebih kurang apa yang kita buat untuk in practice. So sebenarnya based on clinical judgment, clinical skill, tak ada exactly right or wrong lah, ya. Okey, ini adalah case overseas case import, ya. Okey, 23 years old lady, 5th ECT to 7 ECT session. Saya akan bincang ni daripada 5th yang 1, 2, 3, 4, 5 tu saya tak bincang. Saya akan bincang dari session ke-5 hingga ke-7. Dia guna dekat situ untuk patient ni, dia guna right unilateral ultra brief. Dia orang guna MACTA 500Q, ya. MACTA 500Q dengan bezanya yang tadi tu kita bincang adalah 5000 M. 5000 M diguna percentage. Kita naik percentage 2, 3, 4, 10, 20 macam tu. Untuk Q, kita kena adjust parameter dia satu-satu, ya. supaya, dan dosing dia bukan dalam persen, dulu dosing dia adalah milikulum. Kita kena adjust frekuensi, kita kena adjust dia punya apa lagi ya, perlu adjust pulse width, frekuensi, duration, semua tu kita kena adjust. Current dia kita kena adjust. Q ni maksudnya kuat. Maksudnya ada 4 benda yang kita kena adjust sendiri. Okey. Tak apa. Tak penting yang benda tu, tapi kita nak, yang penting adalah kita punya, dia punya EEG pattern. EEG pattern. So, pertama ni EEG dia kita bagi 20 EEG kelima 230 milikulum ya. Kita bagi macam ni strip dia, nampak lebih kurang cantik. Sini tak simetri, tak berapa simetri, tapi okey, satu lagi untuk unilateral kadang-kadang dia tak berapa simetri ya. Tadi kita tak boleh nak betul-betul nak fix, nak guna yang macam nak guna nias tu betul-betul tapi kita nampak more or less lebih kurang kita accept je lah kalau untuk unilateral. Sambung lagi sampai dah satu minit, sambung lagi, kemudian sampai seminit lebih. Nanti kita tengok sampai hampir seminit lebih. Ni ada lagi naik turun, mungkin sawan lagi naik turun. Yang betul-betul flat lebih kurang dekat sini 1 minit 22 saat. Okey, itu satu. Kita nampak agak lama tapi not in definition of prolong yet, tapi kita tengok dia punya pattern sebelum ni. Kita nampak okeylah cantik, regular, amplitude. Lepas start ni dah macam-macam, dah irregular dah. Kejap naik, kejap turun, kejap laju sikit, kejap dia punya keluasan dia ni antara this dengan hujung ni macam sekejap jauh, sekejap dekat. Maksudnya frekuensi dia waves ni dah irregular frekuensi, naik turun. So kalau kita nak kira seolah-olah termination phase dia adalah lebih kurang daripada saat 29 hingga ke saat tadi 29 hingga lebih kurang 21 macam tu ya. Hampir 50 saat termination phase. Very very long. Tadi kalau kita discuss kita nak 5 saat saja ya. Okay, alright. So kemudian next consultant ni EEG ke session kelima. Okay. Next consultant dia just stop here lah. Dia kata dia dah puas hati. Lepas tu this consultant. Next consultant buat bagi same dose juga 230 milikulum. Lebih kurang juga, very very hodoh, irregular ya. Tengok lagi sekejap irregular jadi macam ni, kemudian very hodoh, EEG dia kemudian nampak dah flatten dah macam ni kan. Naik balik dah kau ni. Naik balik sampai betul-betul berhenti dekat 34 second. So kita tengok very long termination phase ya. Daripada 17 saat kan. 17 saat sampai 34 saat. Very long termination phase. Okay. So kemudian yalah, plan dia just continue the same ya. Kemudian ini 7 ECT. Okay, 7 ECT saya pula buat, diorang suruh saya buat. So jadikan praktis kita jangan percaya sangat recommendation dia orang ni. Ya, kita kena tengok sendiri EEG. Ya, kita tengok sendiri EEG. Jadi kita saya tengok balik lamanya termination phase dia. Pasal saya tak tahu, saya tanya ke tidak nurse macam mana patient. Saya rasa saya tanya juga nurse ni macam mana patient ni dalam ward. Okey, kita okey, kata macam tak berapa okey lagi. So saya pun macam naik one step further daripada 230 kepada 345 milikuloms. So kita tengok walaupun seizure dah prolong, dah hampir dah prolong 90 saat, 1 minit setengah. So bila kita naik dos, nampak more regular, more symmetry. Bolehlah ternampak more symmetry dan termination phase tak tahulah, lebih kurang. Mungkin saya rasa pendek je termination phase. lebih kurang tak terchaotic macam ni. Tapi sebab ini unilateral, dia macam tak berapa cantik sedikit. Tapi kita nampak macam lebih kurang quite rapid termination phase ya. Mungkin start kat sini kot dia punya termination phase, ataupun sebenarnya tak ada termination phase terus stop ya. Okey. So kita nampak kat sini inadequate seizure boleh menyebabkan prolonged seizure ya. Jadi kalau kita nampak seizure tu prolong dan EEG start cantik, so kita jangan takut untuk naikkan dos. Kita jangan ingat bila kita naik dos dia akan makin prolong. Tak semestinya. Kalau a lot of time kalau EEG is very ugly and prolonged, if we increase the dose, the EEG looks better, and the length of the seizure would be reduced. Yeah, okay. So itu saja. Thank you very much.
Okay, terima kasih kepada Dr. Khalil atas kesudian doktor untuk berkongsi ilmu pada hari ini. Diharap semua ilmu yang kita dapat hari ini, kita dapat belajar something dan praktikkan dalam kita punya perawatan. Okey, jadi para peserta sekalian, dengan itu tamatlah sudah sesi ceramah kita untuk hari ini. Saya ingin membuka sesi soal jawab. Dan para peserta diminta untuk menjawab post-test. Tadi kita ada buat pre-test, sekarang lepas dah ceramah, kita buat post-test. Link kita ada letak di chat box. Okay, untuk sebarang soalan, boleh juga di-type di chat box ataupun peserta boleh tekan yang raise hand tu untuk bertanya soalan. Untuk post-test, kita bagi dalam 5 minit lah, 5 ke 10 minit untuk jawab. Yang kehadiran tu. Tu Dr. Tan nak bertanya soalannya, Doktor? Dr. Tan
Yes. I'm not sure what went wrong with my video, but good afternoon, good morning still, Dr. Khalil. So I'm Dr. Tan from HDAA. I would like to get your opinion and your experience on the dose titration for the initial dose of ECT by using age. When I start doing ECT, I was taught by using the initial dosing, gauging the initial dosing by using age. It was 80% of the age of the patient. So up till now, I still look at the age of the patient to gauge when to start lah, because I do have this problem of when I start titrate from low, like at 10% or at 5%, we are using time management here, then subsequently I need to like have another, maybe the second one, or if lucky allowed by the NS, the third dosing during the first ECT. I noticed that by increasing the dosing like gradually, it may not give a very good ECT response. That's why I'll choose to have the initial dose at higher dose, higher than the 10% now to get even the first one, the adequate ECT lah. So for example, recently we had a patient about 50, I think 56 years old lah. So the initial dose that I planned during that time was, I started at 20% or 25% lah. So what is your view on that by titrating the dose according to age?
Yep. Okay. You use 8 times 80% lah, right?
Yep. But then that patient, I did not start that high lah, because if by age 50, 80% is already 40%. So yep. I feel that around 20 or 25% may be able to get an adequate ECT response. So I started at 20 or 25% for that patient.
All right. So there are various opinions, yeah, regarding the titration method. I mean, how do we go about the dosing? Firstly, age, according to age, and which some clinician or some books say age divided by 2, 80% of age. Yeah, and then another one is the titration method. Like you mentioned, for me, I would say that you can do according to how comfortable you are with your method. Yeah, I don't have hard and fast rule regarding this. Yeah, maybe it's true. Yeah. If let's say we titrate from very low, it might produce, let's say it might take 1 session or 2 sessions or more to get to the adequate seizure. Yeah, lambat sedikit. Yeah. And then if we use age method, sekali bagi terus dapat seizure. Yeah. Okay. But then the proponent of the titration method says that possibly if we start at a high dose even from the start, higher risk for cognitive impairment. Satu lagi, what we want is suprathreshold stimulus. Yeah, suprathreshold stimulus. We want usually we don't want to high suprathreshold. We want around 1.5 times of the threshold seizure threshold. Okay, so if we use the age method, we might give higher than needed. Yeah, jadi katakanlah the patient, kalau kita guna age method, kita guna let's say we use the titration method, the patient can get the seizure threshold is let's say 15, and then bila kali 3.5 akan 0.5 akan dapat lebih kurang 22.5 macam tu. 20, jadi kita boleh bagi 20, 22.5, 23 ataupun 25. But then if let's say we use the titration the age method, let's say the patient is 60, for example, we already give from the start 30, which is higher than actually needed. Yeah, so I would say up to you. Cumanya kalau discuss dengan neuropsychiatrist, especially from HKL, orang lebih suka titration method lah. Yeah. Yep.
Okay, thank you so much, Dr. Khalil.
Dr. Tan, if I may add a little bit to what I understand, and Dr. Khalil, there is a graph that I can show you later, Dr. Tan, whereby as your dose of your ECT increases, how the seizure threshold initially peaks and then it starts to go down. Yep. So I think the understanding of the titration method, especially the creators of our local guidelines recommend titration and not age titration method rather than using the age. And to my understanding, that is because there is also concern that we may miss the seizure threshold when we increase it too fast. And of course, when we take that into account, that the higher dose may translate to more cognitive effects as well, then I think the age method doesn't seem so favorable. But of course, if the patient's psychiatric risk is very high and we're worried about exhausting too many times to give ECT before we reach clinical benefit, then maybe in patients like that, we should consider maybe not 5, 10, 15, but maybe a bit higher than that. Yeah, would be my opinion of this matter.
Okay, thank you, Dr. Chi, for the input.
Thank you. Dr. Khalil, I have a question.
Ya. Tanya dan jawab sendirilah. Okay. Alright.
Sebenarnya tak familiar sangat dengan the right unilateral.
Yeah.
I think on paper we understand the concept, but in practice, can you share some of your experience with us, and also in relation to the machine, in relation to how we titrate the dose? I mean, we understand that we multiply by 5 to 6 from the seizure threshold, but do we also start from 5, 10, 15?
Yes.
Yes, as well.
Yep.
Okay.
Okay. Alright. So
I was told that the machine, we can use the same one, we can use the same pads. Yeah, but I just...
Okay, all right. So for unilateral ECT, we use the same machine. Okay. Do you use pedal or do you use the strap?
We use we don't use either. We have the disposable punya electrodes.
Oh, disposable electrode.
Yeah.
Okay,
So
all right. But then do you have do you have the electrode machine?
Sorry,
do you have the steel electrode?
We don't. Yeah, it is, from my understanding, missing lah. Yeah.
Missing kena ada. Kena ada.
Yeah.
To have that. Sebab dekat untuk temporal boleh, untuk vertex tu
yang ni
lambut. Yeah. So kena ada juga pedal tu, ya. Kena ada juga pedal. Okay, tapi kalau kepala macam saya boleh lah kot. Guna stiker. Ya. Jadi macam itulah. Adalah setting-setting dia sikit. Kalau saya pun tak ingat dia nak cerita ni. Kalau nak buat, just contact me. Kita boleh buat video call sambil saya korek-korek machine tu.
Okay.
Alright.
Okay, thank you.
Okay, usually we use pedal. First pedal we use at the temporal, and another pedal at vertex. Tapi ada race, kita akan, bila kita bagi stimulation tu, kita akan tertolak kepala sikit, dia akan lari. Jadi kena ada second person, kena bagi letak another pressure on the left side. Yeah. Okay, kalau satu tempat yang saya kerja dulu, dia guna macam pedal juga, tapi yang dummy punya, ya, dia macam pedal, macam handle basikal, macam tu. Macam pemegang basikal tu. Ya, okey. Apa yang kita buat kalau kita tak ada, kita just gulung-gulung gauze, jadi macam cylindrical sikit, just guna untuk tolak.
Okay, that is the ad hoc punya counter force lah. Okay. Alright. Any other questions for Dr. Khalil or me, or even Dr. Tan? Dr. Tan is actually beside me. Maybe if no questions now, maybe 2 weeks later, saya kena buat assessment with the participants. Okay, if no questions, nak discuss soalan post-test tak?
Okay, so saya nak tambah sedikit. Yang slide tadi tu, bila present-presentan baru nampak ada sikit sebanyak silap, biasalah kan, bila dah. Jadi saya akan bagi-bagi sikit, nanti saya akan bagi kepada Dr. Chi dan boleh bagi kepada partisipan.
Alright. Okay. Alright. Dr. Anis, I think I share my screen, then we can discuss the questions. Soalan-soalan post-test. Okay, yang sama dengan pre-test lah. Okay. All right. Okay. So let us run through the questions. Here. Okay. ECT is an effective treatment option for the conditions below, except number 1, depression, number 2, bipolar disorder in manic phase, number 3, self-mutilating behavior in autism spectrum disorder or challenging behavior, Number 4, self-injurious behavior in borderline personality disorder. And number 5, refractory Parkinson's disease. Okay, so the answer is, do I tell the answer now? Post-test dah habis kan? Okay.
Dah, Dr. Chi dah habis.
Yeah, all right, very good. Okay, so the answer is actually self-injurious behavior in borderline personality disorder. Okay, there are some medical indications for ECT. So refractory Parkinson's disease is one of them. For certain very unique selected cases of refractory epilepsy or status epilepticus, ECT can be considered as well. Of course, then the neurologist ke pediatrician ke akan bincang dengan psychiatrist lah. Alright. Of course, when I say here self-injurious behavior in borderline personality disorder, I do not mean a person with borderline personality disorder but having suicidal ideation or high suicidal risk. I'm talking about the way they cope, the way they self-harm. For that, ECT is, we can choose a lot of other ways to treat the patient rather than use ECT for a patient like that. Okay, but of course, if the patient has borderline personality disorder, currently having depression and has suicidal thoughts, of course, then we consider ECT. Okay.
Yep. So for borderline personality disorder, if they have suicidality, if they have self-injurious behavior, we need to know what's the context. Is it the context of major depressive disorder or the context of residual personality disorder? If we know borderline personality disorder, yang dia akan mati hari-hari pun, dia nak kena mati, dia nak mati, macam tu. So if let's say the context of the suicidality is also is due to depression, then the ECT is appropriate. If it's just because of the borderline personality itself, it's not appropriate.
Yeah, so that's what I mean for this question. Okay, all right, question number 2. The mortality rate during ECT, the answer is 2 in 100,000. Okay, and as Dr. Tan Kai Pin mentioned earlier, ECT is one of the safest procedures under general anesthesia. Most of the time, the risk is related to GA rather than our ECT procedure itself. Okay, of course, it still happens. So our consent taking, we shouldn't dismiss the risk. Okay, especially for those yang ada require high risk consent, then we engage our NS counterparts to advise them as well. Okay, all right. So soalan ketiga, the following statements are true except number 1, during seizure, sympathetic stimulation on cardiovascular system may lead to transient tachycardia. Okay, that is true. Number 2, prolonged seizure is defined as seizure lasting longer than 2 minutes based on the EEG recording. That is also true. Number 3, some patients may experience subjective memory loss, although neuropsychological testing is normal, like kita buat MMSE normal, MOCA normal, but they still complain of memory loss. Yes, that is also true. Number 4, ECT is a relative contraindication in pregnancy. This is actually the answer. Okay, this is false in the sense that we actually consider ECT in peripartum situations. Okay, and then finally, ECT is one of the safest procedures done under GA. That is true. Okay. So the next question, question number 4. Below are the adverse effects during ECT except. Ni soalan Dr. Tan, trick question lah. During ECT. So during ECT, you can get arrhythmia. During ECT, you can get oral injuries, you can get prolonged seizure, and there is a risk of asystole. But nausea and vomiting happens after ECT. So this is the answer. Okay. All right.
But the patient can develop regurgitation lah or reflux, it's as in like vomitous reflux. If the patient is heavily pregnant and during the muscle contraction, dia tekan perut tu tekan the abdominal muscle tense and tekan the stomach. Yeah.
Maybe
bukan
the diaphragm.
Yep. Tapi bukan vomiting lah. Yeah. So dalam kes ni mungkin kita kena letak lateral position ataupun kena letak NS akan bagi anti-reflux medication.
Okay, next question. Which of the following medication should be avoided prior to ECT? I think this is something we commonly encounter. Patients that are very unwell, we would sedate with our antipsychotics and also with benzodiazepine. But of course, the medication we should avoid is benzodiazepine because it will omit our seizures, right? Just like how benzodiazepine, other than for sedation, it is also used, say IV Valium or PR Valium is used to abort seizures. So in the same concept, we should avoid in ECT. Okay, so the next question, bitemporal stimulus electrodes are placed at, it is a 2.5 cm above the midpoint of the line connecting the external canthus and the tragus. Okay, dia bukan pinna. Okay, tragus here. Okay. And this is the stimulus electrode that we're referring to, not the recording electrode. All right. And then the next question is, in the diagram below, what phase of the seizure does pink arrow represent? The pink arrow represents termination phase here. Okay. So recruitment phase is red color. Slow wave complexes is brown color. No such thing as climax phase or disorganized phase. Okay, and then looking at this diagram, what is the most likely explanation? Okay, unilateral ECT we see just now, it doesn't look like that. Okay, wrong position will inflect the EEG. Maybe you get an mirror image instead of both upward deflection. Okay, especially if you switch yang EEG1 and EEG2, you switch positions, it will be a mirror image. Okay, if inadequate dose of ECT stimulus or neck muscle spasm, it shouldn't look like that. Okay, so this is actually a loose EEG electrode. Okay, and then next is in the NIRS criteria, which are included except here, recruitment less than 5 seconds is correct. Amplitude of more than 1.5 cm or 3 boxes is also correct. Symmetry of more than or equal to 50% is, but this is symmetry from start of recruitment to end of slow wave. Sorry, is this all correct? Sorry, my bad. No.
PSI tak betul kan?
The PSI, not adequacy. Sorry, I saw the wrong question. Okay, so NIRS criteria includes recruitment less than 5 seconds. NIRS criteria includes amplitude of more than 3 boxes of more than 10 seconds. Okay, but this is for the slow wave complexes saja, as highlighted by Dr. Khalil just now. Symmetry of more than 50% between right side and left side from start of recruitment to end of slow wave. This is correct. Duration of more than 15 seconds from start of recruitment till end of termination. This is also correct. So this one is the one which is wrong. Okay, this PSI should be more than 80%. Adequacy for MECTA is more than 50%. Okay, and the final question is just for fun. ECT machine used in HTAA is Timatron System 4 in particular. Okay, HKL, ada MECTA, ada Timatron. Okay. And now I know that the HSNZ is also using MECTA. Okay, all right. So these are the answers to the post-test. Okay, any questions?
Okay, ada apa-apa soalan ke daripada para peserta? Okay, nampaknya macam dah tak ada apa-apa soalan daripada para peserta. Okay, sebentar lagi kita akan pancarkan semula QR code kehadiran dan isi jail, MMA dan MyCPD. Jadi bagi sesiapa yang belum scan lagi, boleh berbuat demikian selepas kita tutup bengkel ni lah. Okay. Para peserta juga boleh menonton semula rakaman bengkel kita pada hari ini melalui YouTube page Jabatan Psikiatri dan Kesihatan Mental HTAA. Okay, jadi para peserta bengkel yang saya hormati semua, selesailah sudah bengkel kita pada hari ini. Terima kasih yang tak terhingga diucapkan kepada semua penceramah kita, semua pihak yang telah menjayakan bengkel ini dan para peserta yang telah meluangkan masa untuk join bengkel kita. Semoga kita sama-sama mendapat faedah dan dapat mempraktikkan ilmu yang kita pelajari pada hari ini dalam perawatan kita untuk memberi yang terbaik kepada pesakit-pesakit kita. Okay, tadi Dr. Amilin ada bagi pantun masa pendahuluan. So untuk penutup ni saya bagi satu jugalah pantun sebagai penutup. Okay. Bunga dedap di atas para, anak dusun pasang pelita. Kalau tersilap tutur bicara, jemari disusun, maaf dipinta. Kita tutup bengkel kita dengan tasbih kafarah dan suratul As. Okay, sekian, wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh dan terima kasih.